Hi everyone, it's a great privilege to be here with you today, and I hope you'll certainly enjoy my contribution. I've decided to address the question of the history of how the cholesterol hypothesis developed and some of the issues that show that the science is very poor and in fact perhaps non-existent. So I think what's happened in this whole saga is that cholesterol was found guilty of causing heart disease without ever being put on trial. And what I'm trying to do today is to show you that some of the evidence for why the theory was never based on anything that was solid. I think most of you would know how I got to where I am. On the 5th of February 2014, I responded to this lady's request for some information, and I suggested that she should wean her baby onto a low-carb, high-fat diet. And the end result of that was that I was involved in charges of disgraceful conduct as a medical professional, despite the fact that those are the dietary guidelines for all South Africans and in fact for everyone in the world. Those are the standard guidelines that you should be weaned onto a low-carbohydrate diet of real foods. Anyway, it took 4 years to clear my name, and the story behind it I'm not going to bore you with today, but you could read about it in either of these books, The Law of Nutrition, which is the South African edition, or The Real Food on Trial. And thanks to Marika Sporos, who was just a gem in helping write that article and contributing. She did an astonishing job in helping me get the story across, and particularly the story of the trial. So that's all behind me, and I haven't actually given a lecture on low carbs for over a year. But what I've been doing in this time is that I had to research the story of the high-fat diet and how dangerous it was for us, etc. And I got to the point where I thought I knew quite a lot. But after the end of the trial, I decided to carry on and decided to contribute to the CrossFit website, so the crossfit.org. And I originally started writing about insulin resistance. And I wrote 11 columns on insulin resistance, and then that led me into Ansel Keys and his cholesterol con, and I've just completed the 14 parts to that. And during that learning process, I learned obviously a lot, and I learned a lot of stuff that I didn't know before, and which I realized I'd taken on faith as being true, and then I realized it wasn't true. So the key to those columns is that there are 70 events in the last century that have caused us to believe that cholesterol causes heart disease. And I've looked at them in detail, just as Nina Teicholz and Gary Taubes did. I've discovered them and worked on them and looked at the science and collected all the information. And then I decided, well, there were 20 stories that the diet dictators who prosecuted me didn't want you to know. And I'm not going to go through all 20, but I'm going to choose the top 10 that I think are really relevant. Because once you've looked at those top 10, then you'll realize what a scam it's all been. So let's start with number 1. And number 1 will shock everyone, I think, because the claim I make here is that the true cause, and we call the true cause the causa vera, of atherosclerosis or coronary heart disease is unknown. So how can anyone make that suggestion? Well, the answer comes to me after reading these 2 articles by Stephens and some of his other work. And he questions, are you dealing with the cause, i.e. the causa vera, or are you dealing with just a reason for the disease? And he says the problem is the epidemiologists have misled us because they've confused cause and reasons. And until you dissect the 2 and take them away from each other, you're not going to get it right. So epidemiologists confuse cause with the reasons why a clinical disease has developed and ignore subclinical disease, but cause and reason are not synonymous. For cause to have real meaning in science, it must be the sole requisite without which the disease cannot occur. That's critical. Others too have stressed the need for specificity, including Claude Bernard, the great famous French biologist, who argued that it was important in medicine to differentiate between cause and associated or predisposing factors, because anything else would be denial of science in medicine. And he defines the cause must be both necessary and sufficient for the disease to occur. And that's crucial. But the real point is that if you remove the cause, the disease disappears. So if you think you are treating the cause and the disease doesn't disappear, then you're not treating the cause. You're treating one of the reasons. And that's where we've got it so wrong, because the epidemiologists have told us that there are multiple factors causing coronary artery disease, coronary atherosclerosis, because that's how they look at the problem. But the reality is, until you can reverse the disease completely, you don't understand the cause. So that's exactly as Claude Bernard said. Indeed, proof that a given condition always precedes or accompanies a phenomenon, and that's epidemiology, associational studies, the conditions and the phenomenon, that doesn't warrant concluding with certainty that a given condition is the immediate cause of that phenomenon. It must still be established that when this causal condition is removed, the phenomenon will no longer appear, and that's critical. So if we've got a disease like coronary artery disease and we think we know the cause, once we initiate and act against the cause, the disease must disappear. If it doesn't, we don't know the cause. For proof of causation, elimination of the supposedly causative factor must be followed by elimination of the condition being studied. So key is differentiation between causative and non-causative factors is essential. And this is a key point. Reduction in incidence rather than elimination of the disease precludes a causal relationship. So if you think you're treating the cause, but all that happens is the incidence of the disease reduces, but does not disappear, you haven't found the cause. Critical, you haven't found the cause. So elimination of the cause eradicates the disease, and that's the definition. You have to eliminate the cause to eradicate the disease. So cause must be used as the sole prerequisite without which the disease does not occur. So saying that a condition contributes, then it's not a cause, it's a reason. Risk factors are not causes unless proven by other means, i.e. risk factors are reasons, they aren't causes. And so much of what we teach as factors that are associated with coronary heart disease, they are reasons, they're not causes. Clinical coronary heart disease is an inappropriate measure of the severity of atherosclerosis. That's pretty obvious, because you can have severe coronary atherosclerosis without the clinical manifestations, because there's another component, and that's the plaque rupture and thrombosis, which then makes the atherosclerosis clinically apparent. So he concludes misuse of cause, risk factors, and coronary heart disease have led to the multifactorial concept of the etiology of atherosclerosis. And that's led to all sorts of problems. So I had the privilege of debating Professor Jacques Rousseau at the University of Cape Town Faculty of Health Sciences Centenary Debate in December 2012. And this was when I was just starting to get into trouble, and Professor Rousseau was going to make sure that I stopped talking about heart disease and made sure that I believe cholesterol is the major risk factor. And so we had an interesting debate, and he wrote up his side of the argument and I wrote up mine. But this is what he said in his argument. LDL cholesterol is more than a risk marker. It is also a causal risk factor as demonstrated by genetic studies and clinical trials. Well, you can't have a causal risk factor. That's anomalous. It's either a risk factor or it's causal, but you can't have both. And clearly he didn't understand the distinction, and perhaps I didn't at the time, because I should have tackled him on it at the time. So, and that's point one. Point two is that no study has shown reversal, complete elimination of the disease. It doesn't matter whether it's genetic studies or clinical trials. The clinical trials, as we'll discuss, has shown some reduction in incidence, but not removal of the disease. So Therefore, cholesterol cannot be the cause, as I will show you in some detail. Tabas is a very fine cardiologist with interest in the changes that occur in coronary artery disease, and she gave this memorial lecture, and listen to what she says. So this is a person who deals every day with this condition, and you imagine that he or she was very au fait with what's happening in the disease. So how can the overall lowering of plasma LDL over the past 3 decades, that is after the introduction of statins, be reconciled with the fact that atherosclerotic vascular disease remains the leading cause of death? Then Dr. Tabas says, despite the enormous life-saving success of statins, which is not true, as we'll show, issues related to potency, real or perceived drug safety and side effects, patient compliance, and patient and provider education have a limited our ability to lower LDL to the types of level that would prevent the disease. So we need to do more intense lipoprotein lowering is needed. So in other words, the hypothesis can't be wrong. The fact that it doesn't work means that the patients are not complying and we're not getting the cholesterol low enough. Actually, no, Professor Tabas, the patient's non-compliance is not the problem. The problem is that lowering the blood cholesterol concentration does not prevent coronary heart disease. So elevated blood cholesterol concentrations are not the cause of coronary heart disease. Your hypothesis is wrong. And you would think that after 30 or 40 years trying to prove that cholesterol causes coronary atherosclerosis and without achieving anything, that these cardiologists would like to change their hypothesis, but that's pretty impossible, it seems. Peter Libby, I had the pleasure of debating him in Cape Town. He's professor of cardiology at Harvard. And here he has an article called The Forgotten Majority. And who's the forgotten majority? The forgotten majority is people who are taking statins who still have heart attacks, which shouldn't happen if the statins are removing the cause, which is the elevated blood cholesterol concentration. And he says very similar to what Professor Tabas said. Despite meaningful progress in the identification of risk factors, deaths from cardiovascular disease continue to increase worldwide. Although pharmacological treatments with statins have reduced cholesterol levels and lowered mortality rates, that is false. They haven't lowered mortality rates. Several large controlled clinical trials have indicated that cardiovascular events continue to occur in, wait for it, 2/3 of all patients. I don't think he means 2/3 of all patients. What he means is 2/3 of all patients who have a heart attack are still taking statins. And that's an important distinction. Although lifestyle modification benefits general health, most people continue to resist changes in their daily routines. So in other words, the patient's at fault. Can't be the hypothesis is wrong. Cholesterol we know causes heart disease, and therefore if we can't get benefit from statins, it's because the patients are not listening to all the good advice we're giving them. So here's a figure from his article, and he's looked at 6 major clinical trials of statins, and you'll notice that they've included lots of patients. This study had 20,000 patients, and he's going to see what were the major coronary events in the patients who were on the statins. Now, if statins reverse and prevent coronary heart disease because cholesterol is the cause, then the incidence of heart attacks in people who are on these trials taking statins should be 0, as indicated here. It should be right there, 0. So let's see what it is. Oops. There are all the clinical trials, and showing therefore that this is an important point, that 75% of the heart attacks occur in people who are taking statins in these trials. So therefore they are not reversing the condition, and therefore a lower cholesterol or cholesterol itself cannot be the cause of coronary atherosclerosis and coronary artery obstruction and heart attack. So conclusion, an elevated blood cholesterol concentration is not the cause of error of clinically apparent coronary heart disease. And he concludes, we've had that one. So actually, Professor Libby, you're wrong. If drugs that lower blood cholesterol concentrations to the normal range do not prevent further coronary events in those with initially elevated blood cholesterol concentrations, then cholesterol is not the cause of error of the coronary events. Your hypothesis is wrong, and it's time to think about another hypothesis. So here's an article by Foss, Rose, and Byron in 2013, and the great statement somewhere there is the lack of circulating statins is not the cause of atherosclerosis. That's a very good point. So if you were to replace the cause, which is the lack of statins, you replace it with statins, your disease has to go away. He makes the point that in these studies, the 2005 CTT analysis, one would have to treat approximately 1,900 patients with statins for approximately 1 year to extend the life of one person. Statistical significance loses all meaning in this context because the finding is obviously not clinically relevant, as the benefit is extremely small and is not applicable to women. So there are some of the opinions that statins are not reversing coronary artery disease, therefore what they're acting on, which is to lower the blood cholesterol concentration, cannot be the cause. It may be a reason, maybe one of many reasons for coronary atherosclerosis, but it's not the cause. So my conclusion is, if significant lowering of blood LDL cholesterol concentrations does not prevent the disease, then LDL cholesterol is not the cause of error of coronary heart disease. Accordingly, the blood cholesterol concentration is one of the reasons for coronary atherosclerosis. It is not the single real cause, the cause of error. Since no one other than Dr. Fred Kumerow, who we discuss later in this series, has an alternative explanation, I conclude that the cause of coronary atherosclerosis is and remains unknown. So we move on to point 2. And my second point, which again I didn't know because no one had ever told me, and one had to dig deep to find it, was that John GOFMAN was actually the person who developed the diet, heart, and lipid hypotheses, and his ideas were then stolen by Ancel Keys. So here's John GOFMAN on the left in the 1960s, when he had become known as the father of clinical lipidology because he had developed the ultracentrifugation technique, which had allowed him to identify the different lipoproteins in the bloodstream. He got so disillusioned with the field that in the 1970s he moved on and went and looked at the dangers of radiation, particularly X-ray radiation to humans, and became a world authority and won all sorts of awards. So here's a man who had 2 careers, and you have to ask, why would he change his career from getting this award in modern medicine to going into the studies of a completely separate field? And the answer, I believe, was that he was driven out of the field by Ancel Keys, and he realized that the field was going in the wrong direction. And I'll explain exactly what I mean by showing you what his work showed. So remember that Ancel Keys really starts talking about the diet, heart, and lipid hypotheses in 1953. But in 1956, here we have an article which John GOFMAN is the first author, titled Evaluation of the Serum Lipoproteins and Cholesterol Measurements as Predictors of Clinical Complications of Atherosclerosis. So he had real data in 1956, long before Keys had even turned his thoughts to how he was going to get these data. And he was the person who gave us these different lipoprotein families. And just to remind you of the different lipoproteins and their constituents, I just want to remind you that the VLDL has made a large contribution from triglycerides, whereas LDL has a major contribution from cholesterol. And it's really important because what we're going to show is that GOFMAN realized very early on that LDL was increased somewhat in people eating higher fat diets, but he also recognized at the same time that triglycerides in the VLDL lipoproteins was increased by carbohydrates. And he gave equal measure, in my reading, to both of those as potential causes of coronary heart disease. And it was Keyes who wrote out the carbohydrate story, as I'll show you. And ultimately, on July the 1st, 1965, the carbohydrate story was completely lost, as they were whitewashed and health washed by some Harvard professors who were bribed to do it, but we'll get to that. In the meantime, we need to remember that Keyes and GOFMAN differed in that Keyes did not consider that carbohydrates contributed anything to heart disease. So here's a diagram of what GOFMAN was measuring. GOFMAN was measuring the flotation rates of the different lipoproteins. And you can see on the top are the specific lipoproteins, VLDL. So that's wrong. It should be, it's very low density lipoproteins. The intermediate density lipoproteins, low density lipoproteins, and high density lipoproteins. And the flotation numbers, which was what he worked on, he differentiated a group that were from 0 to 20 and from 20 to 400. And this is the size of the different lipoproteins. And in blue is their concentration in the bloodstream. So you'll see that the LDL is the most prevalent lipoprotein. So he focused on the 0 to 20 and the 20 to 400 flotation rates. And he showed early on that the 0 to 20, which is the LDL and the IDL, is increased by dietary fats, whereas the 20 to 400 is increased by dietary carbohydrate. And that's critical, as I'll show you. So here's a paper in 1950, long before Keyes has ever considered the diet heart hypothesis. And this is the information that the article includes. Individuals of both genders with myocardial infarction displayed a very high frequency of occurrence of the SF10 to 20 molecules in the serum, and that is LDL cholesterol, as I showed you. And the presence of these molecules supports the hypothesis of their association with atherosclerosis, and that is the lipid hypothesis described in August 1950 by Dr. GOFMAN. A group of patients prescribed a strict low-fat and low-cholesterol diet for periods of 3 months to 3 years had lower concentrations of the LDL class than either normal or other myocardial infarction patients, and that is the diet heart hypothesis. So there they are, described in 1950. So by 1950, GOFMAN had already formulated the diet heart and lipid hypotheses, and Ancel Keys was nowhere to be seen. GOFMAN in 1954 published an article saying that he had worked out something called the atherogenic index, and that was based on the flotation rates and the concentrations of the different lipoproteins in people with heart attacks. And he said, according to his units, if you had more AI units, then your risk of heart disease was increased. And he even showed that in male coronary artery disease patients on the right, there was the A1 values were shifted to the right. So you can see the mean values at about 100 compared to about 70 in patients who did not have coronary artery disease. So that again is the lipid hypothesis, showing that he measured something in blood that he linked. It was a lipoprotein pattern that he linked to increased rates of coronary heart disease. He wrote 2 books. This was one of them. The other one was What Do We Know About Heart Attacks? These books were written for the general public, and I couldn't get the copy of the cover of the 1960 article, so I've used the one that I do have on the left. And this is what he wrote in the book on the second book I mentioned. In many individuals, the risk of coronary heart disease comes primarily from the SF20 to 400 lipoproteins. For such individuals, any attempt to lower heart attack risk by shifting from animal fat to vegetable fat would be illogical. For such individuals, the preventive efforts would have to be directed towards lowering the carbohydrate intake, which will on the average reduce the SF20 to 400 lipoprotein levels. And remember, the 20 to 400 lipoproteins are the VLDL triglyceride-rich concentration. So he understood that the lipoproteins, the triglyceride-rich VLDL, is influenced by the carbohydrate content of the diet. And he was the first to appreciate that. There were many others who subsequently realized it, but he was one of the first. So here's another publication of his diet in the prevention and treatment of myocardial infarction, published in the American Journal of Cardiology in 1957. And in this article, he took a single patient who'd had a heart attack, a myocardial infarction survivor, and on the patient's usual diet, which was not low carbohydrate, the patient had increased concentration of triglycerides, the SF20 to 400 lipoproteins, but the concentration of cholesterol was according to the black columns. The patient then went on a low carbohydrate, 100-gram carbohydrate daily diet, and you'll notice that triglycerides rapidly fell and stayed low for the duration that the person ate 100 grams of carbohydrate daily. Cholesterol values did not change. Despite this, the atherogenic index, notice, fell as well. That's in blue. So according to GOFMAN, this patient had benefited even though his cholesterol had not reduced. His cholesterol had stayed the same. His triglycerides had fallen. And so he said a massive fall in the serum SF20 to 400 lipoprotein levels occurs on the low carbohydrate diet without significant changes in the LDL levels. Accompanying this fall in lipoproteins is a highly marked and favorable reduction in the atherogenic index value. So what GOFMAN is saying here is that changing to a low carbohydrate diet was very beneficial for this patient and should have reduced the patient's risk of future heart attack. And he concluded ultimately a statement that got hidden. Neglect of the carbohydrate factor can lead to serious consequences, first in the failure to correct the diet in some individuals who are very sensitive to the carbohydrate action, and second, by allowing certain individuals sensitive to the carbohydrate action to take too much carbohydrate as a replacement for some of their animal fats. His work then was confirmed by Peter Q. from Philadelphia, and here's a paper he wrote in 1967. And Peter Q. ran a clinic for lipid abnormalities to which patients were referred by cardiologists who wanted a dietary management for their patients. And what he discovered was that the patients were sent to him because they had high cholesterol levels. And he was able to differentiate between those who had essential familial hypercholesterolemia, who were the minority, only 8%, from those who had hypertriglyceridemia as the primary problem, associated in some with hypercholesterolemia and others with not with hypercholesterolemia. So here you see 28 patients, or 9%, had high triglycerides but a normal cholesterol, but the majority of patients had a high cholesterol and high triglycerides. So here we move on, and he says, although the majority of patients with atherosclerosis in this series were referred to us for the investigation of hypercholesterolemia, only 8.4% were found to have essential familial hypercholesterolemia. More than 90% were found to have carbohydrate-sensitive hypertriglyceridemia with or without hypercholesterolemia. Thus, it's reasonable to assume that with proper dietary preparation and appropriate laboratory studies, a high incidence of carbohydrate-sensitive hypertriglyceridemia could be demonstrated in persons with atherosclerosis. And so this is one of the first studies to suggest that. He then showed that if you took patients with carbohydrate-sensitive hypertriglyceridemia and put them on a low-carbohydrate diet, you notice that their triglyceride levels fell dramatically, whereas the cholesterol levels also fell, quite surprisingly. He then took 64 patients over 16 months and confirmed that if you had carbohydrate-sensitive hypertriglyceridemia, your triglyceride levels could normalize during that period, and cholesterol levels also dropped a little bit. So he concluded that since patients with carbohydrate-sensitive hypertriglyceridemia suffer primarily from disorders involving exaggerated biosynthesis of triglyceride-rich lipoproteins from carbohydrates, carbohydrate restriction should constitute a feasible form of treatment. For practical purposes, it's necessary to eliminate all dietary sugars, sucrose, fructose, and lactose, on account of their high lipemic, insulin-stimulating effects and low satiety value as compared with starches, or to lower carbohydrate consumption to about 500 calories per day, which is about 120 grams of carbohydrate. He also found that the sensitivity to simple carbohydrate is widespread among both healthy and atherosclerotic populations. In persons on an ad libitum American diet, lipogenic activities from simple carbohydrates appear to vary from low levels in young girls to very marked degrees in patients with atherosclerosis who are sensitive to carbohydrates, with apparently healthy men somewhere in between. So he's recognizing insulin resistance as a driver of hypertriglyceridemia and showing that with age it gets worse, and also a gender effect. So he concludes that the role of this variable cellular response to carbohydrates in human atherosclerosis, as reflected by a rise of very low density lipoproteins and serum triglyceride levels, deserves further and more intensive investigation. And this never happened, and I'll show you why. Because on November 1967, the New England Journal of Medicine published a paper from three Harvard professors saying that carbohydrates were healthy in heart disease and fats were unhealthy. And we'll get to that. But this was the end of the debate. So Q and GOFMAN and others had raised the question that carbohydrates are causing heart disease, and there was plenty of evidence for it, but Keyes had driven the high fat story, and this article was forgotten when the Harvard professors said that sugar and carbohydrates were safe. So this never happened, and instead the focus shifted to cholesterol and the role of dietary fat in the causation of coronary atherosclerosis. And that is the further story that I'll be picking up in the second half of this lecture. So we've discussed how John GOFMAN was the first to describe the diet, heart, and lipid hypotheses. So the next question is, well, how did Ancel Keys become recognized as the father of those two hypotheses? And that's the point we'll describe here under point number 3. So Ancel Keys stole the idea of the diet, heart, and lipid hypotheses from John GOFMAN, as it was his final chance for immortality. What you need to understand that in the 1950s, the US government had enacted a new law which invested a huge amount of money into heart disease research. And so there was going to be a scramble to see who could get the money. And the first person out of the blocks was obviously John GOFMAN, because he had all the qualifications to lead it. But Ancel Keys had no qualifications. He was a physiologist, he was not a cardiologist, he was not medically trained. And so he had to find some way to usurp the position of John GOFMAN. And I'll explain how he did that. So Ancel Keys stole this idea that what you eat raises your cholesterol. If you eat a high diet high in saturated fats, raises your cholesterol. That clogs your arteries, and then that causes the clinical manifestations of coronary heart disease. Now, instead of going through each of those steps in detail, he kind of did the shortcut. And so his link was point 4 on this graph. And he did studies in different countries, as I'll show, and I'll show you how he found those data, that countries which ate more saturated fat supposedly had higher rates of coronary heart disease. So initially, his whole basis for his hypothesis was he didn't go through stages 1, 2, 3, and 4. He just went through stage 4 and pretty much ignored the 1, 2, and 3. So he developed his models on the basis of association epidemiological observational population studies that suggested that link, and that was the basis for the model. And sadly, it became ingrained that the associational data were good enough and that we should therefore accept numbers 1, 2, and 3 on the basis of the relationship between diet and country rates of coronary heart disease. So here's the famous graph that he developed, and in which he had a relationship between the percent calories from fat and the CHD death rates in those countries. Now the question is, where did he find those data? And the answer is he was glancing through some information one day and he came across this WHO Annual Epidemiological and Vital Statistics document, which had these two graphs. On the left was the relationship between fat and heart and deaths, and on the right was calories from animal protein. And he then took out the 6 red dots, as you can see, and he excluded the relationship between calories from animal protein, which you can see appears to be a rather better relationship. So he collected his 6 countries, and that's where he got the data from the World Health Organization. So someone else went and looked at the consumption of visible animal fat in all the 22 countries, and he showed that there were 2 clusters, one with a low consumption of visible animal fat and another with high animal fat consumption. And Keyes very cleverly selected 4 countries from the low visible animal fat consumption, and he chose the 2 countries with the highest visible animal fat consumptions, the 2 countries with the highest rates of heart disease, which also happened to have quite a high rate of saturated fat intake. So on the basis of all those 7 countries, he came up with his remarkably exponential graph. But you can see that had he chosen some of those countries, he might have found it a little more difficult to find that relationship. In 1955, these 2 workers, Jerushalmi and Hillebogue, wrote a paper which was the result of a conference at which Keyes spoke, and these 2 professors spoke. And they were very critical because they said there were 26 or so countries that he could have chosen, 22 countries he could have chosen, but he selected those ones that fitted closest to the line. And they made the point that epidemiology doesn't explain causation. It can find reasons for disease, but it can't explain causation unless the relationship is very, very strong. So they said the evidence from 22 countries for which data are available indicates that the association between the percentage of fat calories available for consumption in the national diets and mortality from atherosclerotic and degenerative heart disease is not valid. The association is specific neither for dietary fat nor for heart disease mortality. And they showed that there were a number of other correlations which were rather stronger. So they concluded clearly this tenuous association cannot serve as much support for the hypothesis which implicates fat as an etiological factor in atherosclerotic and degenerative heart disease. The tragedy, as everyone knows, is this became the basis for the low-fat theory that eating a low-fat diet will prevent heart disease. And it was, as these scientists pointed out, it wasn't acceptable evidence. So to prove their point, in their paper, they took 6 countries and they showed an inverse relationship between the deaths from stroke and the consumption of fat calories. So that Japan, who had the highest rates of stroke, had the lowest rate of fat from calorie consumption. What's really interesting is that in all these studies, Japan is always chosen to anchor the left side of the graph. And Japan's a very interesting country because it has high rates of stroke, but low rates of coronary heart disease. And we'll come back to that later. So the point that the scientists were making was that if you look at associational data, you can come up with any relationship you want. And they were trying to make the point that how can Japan if cholesterol is a key issue and fat intake's a key issue, why does Japan have a high rate of stroke and a low rate of heart disease, whereas the United States has the opposite relationship? I was reading this book recently, and Alice Stewart is one of the world's famous epidemiologists who was never recognized properly, largely because she was a woman and she was working in Richard Dole's laboratory, and he didn't think much of her, and he was in competition with her. You remember that Richard Dole was the epidemiologist who found evidence that cigarette smoking causes cancer. Well, she found from her own studies that low-level radiation given to a fetus in the mother's womb causes an increased risk of leukemia in childhood. And it was a phenomenal finding, probably Nobel Prize winning stuff, but she wasn't ever really acknowledged. And in the book there's this paragraph. And so I say, epidemiology ain't so simple, Ansel. This only looks simple, but it's far from simple, and it amazes me, Alice Stewart, that people think they can just count a few things, make a few correlations, that they can just step into epidemiology from another subject, be a physicist or something, and then become an epidemiologist overnight. Epidemiology requires a great deal of skill and training. And that's the truth. And the truth is that Keyes did not have that training. He simply came across this World Health Organization document. He usurped it as his own, and that kicked off this whole story that cholesterol causes heart disease. So here we have the relationship, and I'm going to focus a little bit on Japan because Japan is such an interesting country. Japan has to anchor the left side of this graph. So what you would think, of course, is, well, Japan must be doing pretty well in heart disease rates. They're pretty low. There's nothing more they can do to make it lower. Well, it turns out they did do something, and they reduced their rates of heart disease lower. And what they did was the exact opposite to what Ancel Keys said they should do to lower their heart disease rates. And this is a fundamentally important finding, because Keyes used Japan as a crucial part of his story. But yet, in the years since he drew this graph, heart disease rates have gone down in Japan as they've increased their fat consumption. So that in itself destroys his hypothesis. And I might add that on this graph, Italy has shown the same response. They have also increased their fat intake and their heart disease rates have gone down, as have Spain and Switzerland and a couple of other European countries. So here's the evidence, and what it shows is, if we start at the bottom, we'll see that in 1946, Japanese had 12% of their energy in their daily energy intake was from protein, 7% from fat, and 81% from carbohydrates. And then if we look on the second curve, you'll see that the carbohydrate consumption has fallen, and that's registered on the bottom graph. You'll see that the calories from carbohydrates went from 80.6 to 59.2. And what's happened to replace the carbohydrates? Well, total energy has gone up slightly, but fat and protein from animals has gone up. So if we look here at the yellow curve in the third from bottom graph, you'll see that fat from animals has increased from the 1950s to the 1990s. Other fat sources have increased as well, but also protein from animals has increased substantially. So the fat consumption of the Japanese has gone from 7 to 25% during this period. Here's the data for carbohydrate intake, and you can see that total grains and rice have gone down. Potatoes and wheat potatoes have gone down. Wheat stayed pretty much the same. You'll see that some of the fruits have come up. Confectionery has increased initially and has dropped down again, and sugar has stayed pretty constant since the 1950s. But notice fish consumption has gone up. Milk and dairy produce has gone up, meat has gone up, and eggs have gone up. Now, these are exactly the foods that Ansel Keys says we should be avoiding to prevent heart disease. So this evidence here is good enough to disprove his hypothesis. Now, what happened to cholesterol in Japanese during this period? That's the blue line at the bottom. And you can see in the men and in the women, it's gone up substantially to become the same as other countries. These are 6 or 7 other countries in which cholesterol has been coming down since the 1980s. And despite this, heart disease rates have not gone up in Japan. They've come down, and so have the stroke rates, which is relatively remarkable. Now, because the Japanese are such an interesting population, a large number of studies have been done on Japanese living either in Japan, and that's called the Nippon component of this title, in Honolulu, Hawaii, or in San Francisco, California. So this is the Nihon-san study. And this was designed to show what happened when the Japanese went to live in Hawaii or California. And what you see is that for any risk factor, be it blood pressure in the left graphs, cholesterol levels in the middle graphs, or smoking on the right graphs, you'll see that the Japanese living in California are at much greater risk of heart attacks and development of coronary artery disease than are the Japanese who continue to live in Japan, with the Japanese living in Hawaii in the intermediate position. And this occurs across all the risk factors at any level of risk, which we can't explain, because this tells you that there's something in the environment which we aren't measuring, which is linking to the risk of heart disease. So this disproves the idea that risk factors carry all the evidence, i.e. blood pressure, cholesterol, and smoking carry all the evidence we need to know about a person's risk for heart disease. It's very clear that they don't. But what's even more interesting is that although heart disease rates may differ apart in these countries, depending on where the Japanese are living, total mortality is not different. So that's the remarkable point. Although the prevalence of all CHD events was strongly influenced by where the study participants were living, importantly, total mortality was the same in all 3 groups of ancestral Japanese, regardless of where they lived. So we really have to be very cautious when we think we know what's causing heart disease. As I showed in the very beginning of these lectures, we really don't know what causes heart disease, and risk factors aren't very helpful in telling us more, because there's something that we're completely missing. Clearly, it's important to distinguish between the causa vera, the real cause, and the reasons for coronary heart disease. To re-emphasize, we do not know what causes coronary atherosclerosis and coronary heart disease. Now, here's another really interesting study by Thomas J. Thom. He looked at 26 countries and measured their trends in total mortality and mortality from heart disease in the years 1950 to 1978, when heart disease rates were initially going up, and then in the 60s they were beginning to fall in the United States. So he's looked at 26 countries, and he's also looked at men and women. And let's begin with the women, because that's easy. You'll see here are all the different countries at the top, the 26 countries. And each of these graphs is made up of 6 time periods. So what we see on the left is that the women in the United States, the heart disease rates have been falling dramatically since the 1950s. Whereas in the men, the fall was not quite as fast initially, but then it's become rather more rapid. Whereas if we look at other countries like Norway, you'll notice that in Norway, the heart disease rates in men were going down, and in women they were going up. And that's really interesting, because the Norwegians are eating the same diet, whether they're men or women, and they're probably exposed to other similar environmental factors, yet the heart disease rates were different. So again, this is to confirm that we can't just take the United States as an example of what's happening across the world. We have to consider every country differently and separately. And Keyes really perhaps didn't do that, because he was suggesting that there was one size fits every country. And what this shows is not only is it not one size fits all for each country, the men and the women are different. Again, confirming that epidemiology is misleading if we're going to think that we can take a singular example of one country and apply that evidence to all other countries. So now point 4 is that Keyes had come up with his hypothesis in the 1950s, and it had been very widely accepted and really had been incorporated by the American Heart Association and the National Institute of Health. And they were funding his research, the research of this idea. As I'll show subsequently, at the time that Keyes was promoting his ideas in the 1950s, the late 1950s, there were two competing theories. The one was that carbohydrates cause heart disease by elevating blood triglyceride concentrations, and the other was that it's cholesterol in the blood and it's elevated by a high saturated fat diet. And they were equal. But the US government, for reasons that I'll explain, threw out the sugar story and the carbohydrate story and stuck with Keyes's theory. And what really was so instrumental was in 1977, George McGovern's Senate committee came together, and because they were about to be disbanded, they decided they had to do something. And they chose to lay down dietary guidelines for all Americans. And that was catastrophic, because that stopped the debate. Once the government had said this is what you have to eat, despite the fact that there was much debate about whether those guidelines were correct or not, once they'd laid down the guidelines, they were immutable. And that we see even today, because as I speak, the 2020 dietary guidelines are about to be released, and it's very clear that they still don't look at all the evidence. So the essential basis for Keyes' hypothesis is the diet of the average American changed radically after about 1910. And what I'm going to show to you, because that was the evidence that McGovern used to say that we have to change diet to what we should be eating, which is what we used to eat in America, which was our diet high in cereals and grains. And the point is, it was never that. That was never the case. So in fact, the major chain of Americans in the past 100 years is the one that is ignored. So here we have Senator McGovern in front and his committee. They met over a few days and drew up these guidelines, which became so influential. And here was McGovern on the first day of the commission. This is what he said. The simple fact is that our diets have changed radically within the last 50 years with great and often very harmful effects on our health. These dietary changes represent as great a threat to public health as smoking. Now, smoking by then was accepted because the data had shown that it was a factor. So then he continues, too much fat, too much sugar or salt can be and are linked directly to heart disease, cancer, obesity and stroke, amongst other killer diseases. And that's not true, because there was no data at that time to say that fat and sugar and salt had been linked to all these diseases. In all, 6 of the 10 leading causes of death in the United States have been linked to our diet. They may have been linked, but that's by association. There was no proof at that time that the diet that's high in fat and salt and sugar is the one that's the problem. Now, another person who was very influential in the US at the time was Jane Brody, and you can see she wasn't a fan of the low-carbohydrate diet. She promoted high-carbohydrate diets. And she said within this century, the diet of the average American has undergone a radical shift away from plant-based foods such as grains, beans and peas, nuts, potatoes and other vegetables and fruits, and towards foods derived from animals, meat, fish, poultry, eggs and dairy products. So she's confirming what Senator McGovern was trying to say. The problem was, what was the evidence base for that statement? Had the Americans really changed the diet in the way that Brody and McGovern had claimed? Well, let's look at the rise in total heart disease, and that's in red, and you'll see that the rise starts in about 1900 It peaks in the 1950s and then starts to fall. If we remove the infectious and other causes of heart disease, so we talk only about coronary artery disease, you can see that the rise seems to start in the 1940s and then comes down. But this value must have started rising here in the 1920s. And as we know that heart disease, there's a latency period of at least 30 years. So that means the diet must have changed in about 1890. That's where the change should have occurred. Included on this is just for everyone's sake to realize that the stroke rates have been falling, so just from the 1900s. So the same, if the diet's the cause, here's a diet that causes heart disease but protects against stroke. And no one ever mentions that point. We're always told that the biology of stroke and heart attack is the same. But how can it be the same if the same diet, and if diet's the cause, the same diet's preventing strokes and causing heart disease? That's an anomaly that people fail to address. Nina Teicholz, in her brilliant book, from which I garnish so much information, as we all do, she has this graph, and she goes back and she says, well, if you go back to the 1800s or before, Americans had to be eating mainly meat because they hadn't started growing grains when the Americans first arrived in North America. They can't have been eating grains and fruit and vegetables. They had to have been eating meat killed locally. So she collects the data and shows that, or argues that the total meat consumption was higher in the 1800s than in the 1900s. It fell further to 1940. And remember the heart disease epidemic, the factor must have changed in about 1890 here. So you've got a falling meat consumption and a rising heart disease rate. Subsequently, the consumption of meat has gone up, total meat, because of the increase in poultry. It's not because of the increased consumption of red meat. So if you want to find a meat that's causing heart disease, you have to look at poultry, and Keyes and his colleagues never focus on that point. Mary Enig is one of the great scientists who's also been under-recognized. She was very interested in trans fats and the problem that trans fats cause to human health. And in her paper, she says total fat consumption in Americans has definitely increased from 1909 to the 1970s, but the animal fat consumption has stayed pretty much the same, as you can see. What's really changed is the consumption of vegetable fats, polyunsaturated fats from hydrogenated vegetable oils. And there you can see a tremendous increase, and it's starting to take off in the 70s. And when she calculates that as a percentage for each individual, you can see that the animal fat consumption's actually gone down as a percentage of total calorie in consumption, and to be replaced by vegetable oils. So if you're looking here, you would say what's really changed in the American diet is vegetable oils, and in this particular case, linoleic acid. Another analysis shows that Ansel Keys's ideas were adopted, because you'll notice that the consumption, he said we shouldn't eat butter, we should eat margarine. Well, the butter consumption's gone down, lard consumption's gone down, margarines come up substantially. But look at shortening, and shortening is the polyunsaturated fats that are used in baking. And you can see it, if you really want to look at a factor that's really changed, it's the consumption of shortening, and which particular vegetable oil is taken off. It's soybean oil, and that's taken off after the 1960s. And the 1960s were when the American Heart Association started following the Keyes' idea and promoting the consumption of margarine and polyunsaturated fats, particularly soybean oil, to replace butter and lard in the diet. And this then is a time course of changes in oil consumption and fat consumption by Americans. And you can see that here we have all these events that happen. But the real event that changes everything was the American Heart Association Advisory Committee in 1961, which finally accepted Keyes' ideas. And they said Keyes is right, whereas in 1957 the advisory had said that there was no evidence to support Ancel Keys. By 1961 they decided to support him. And the only reason they decided to support him was because the new committee was controlled by Keyes, and he managed to get his mate Jeremy Stamler included. And with Stamler's support, the American Heart Association changed its guidelines and said we need to change the diet and replace saturated fat from animals with polyunsaturated fats. And you can see how effective this was, because that then the consumption of soybean oil increased dramatically thereafter. So this advisory in 1961 had a huge effect. And then we're talking now about the 1977 US Senate Committee, which also helped push the consumption of polyunsaturated fats. At the same time, there was a change in carbohydrate consumption, and the increase was in sugars and syrups and simple sugars, with a reduction in complex carbohydrates, with the result that the ratio of complex carbohydrate to simple carbohydrates fell. So that also happened. But you will see that, so if you wanted to link carbohydrates to heart disease changes in the United States, you'd have to say it was the consumption of sugar and syrups and the reduction in complex carbohydrates that are related. But here's the really important slide, which people haven't really referred to, and it was written in 1964, and that's probably why people have not seen it. But here's the consumption of polyunsaturated fats, which start in 1909, which is just when it needs to start if you're going to cause a rise in heart disease rates in the 1940s. So polyunsaturated fatty acids start to increase, but here's the key. The change in the polyunsaturated to saturated fat ratio starts to rise already in the 1920s. Now along comes the McGovern Commission, and they say that on the basis of Keyes data, we have to change the PS ratio. And they talking about in the 1970s. Well, actually, the PS ratio has already changed at the very time that heart disease rates are going up. So how McGovern could think that increasing the PS ratio is going to reverse the heart disease rates when it's exactly what had changed during the time that heart disease was becoming so-called epidemic. How he was able to make that suggestion is nonsensical. And here is the evidence that we realize why he had to be wrong. And rather than praising polyunsaturated fats as preventive for heart disease, we should be asking the question, what's going on here? So the author said, obviously these data do not fit the hypothesis that low ratios of polyunsaturated saturated fatty acids in the food supply contribute to the increased incidence of coronary heart disease in the United States. The changes which have occurred in the type of dietary carbohydrates may, however, be a factor. And that's true, and we have to consider it. But the real question we should be asking, but what if it was the increase in polyunsaturated fatty acid consumption, including trans fat consumption, that caused the CHD pandemic? And you see, we're also brainwashed to believe that polyunsaturated fats are healthy, that we don't realize the change occurred in 1909, that Americans started eating more polyunsaturated fats and the rest of the world in 1909, not in 1977 when the McGovern Commission brought out its new dietary guidelines. Just to make the final point, that there were many people like Pete Ahrens, who we'll meet at length. He was one of the first to start describing carbohydrate-sensitive hypertriglyceridemia. And he made the point when these dietary guidelines came out in 1977. He has an editorial in The Lancet. He said a trial of the low-fat diet recommended by the McGovern Committee and the American Heart Association has never been carried out. It seems that the proponents of this dietary change are willing to advocate an untested diet to the nation on the basis of suggestive evidence obtained in tests of a different diet. Their logic is presumably justified by the belief that benefit will be obtained vis-a-vis coronary heart disease prevention by any diet that causes a reduction in plasma lipid levels. So what he's saying is that there were data at the time of these dietary guidelines being produced or introduced. There were studies of changing saturated fat for polyunsaturated fats, but no one had ever tested a low-fat diet. And in the rest of the lectures, I will be focusing on those studies where they've changed either the polyunsaturated fat to saturated fat ratio, or where they've reduced the saturated fat content of the diet, to see, did those studies ever, subsequent to this acceptance of these guidelines, did those studies ever prove that we should have adopted these dietary guidelines? So in point 5, we move on to discuss some of the more critical studies which were launched to try to prove the Keyes hypothesis. So I think it's really important to make the point that many of these original studies were not really designed to disprove Keyes. They were driven by people whose goal was to prove the diet-heart hypothesis. And the reason simply was because there was so much money in the business that it was rather easier to support Keyes and his ideas than to conflict with him. Because I suspect if you decided to take on Keyes, you'd lose funding, because that was how much control he had of the American Heart Association and the National Institute of Health, who were the premier funders. So in the early 1960s, Keyes did his first randomized control trial, the Minnesota coronary experiment, which was a remarkably good experiment in which, as I'll show you, he changed the diets of certain institutionalized patients, and it was meticulously done. The problem was that the study disproved his hypothesis, so the data had to be hidden. Those data were then subsequently recovered, and that we call the recovered Minnesota coronary experiment. And then that exposed the so-called Sydney diet-heart study, which was also recovered, and that also showed that the data had been hidden because it disproved his hypothesis. And then the Women's Health Initiative, which I go into in some detail, a $700 million experiment, which also disproved the low-fat diet, that also had to be hidden. The findings had to be hidden. And so that's why most people do not know anything about these 3 trials. And I'm going to go through them to show you that these trials are terribly important. And in my opinion, they prove that it's unethical for anyone to remove saturated fat, to be told to remove saturated fat from their diets. So that if you're a clinician and you advise people to replace saturated fat with polyunsaturated fats, these 3 studies show that's unethical because it'll do harm. Now the studies were hidden, and that's why people don't know about them, because they were meant to show the opposite. And as soon as they produced evidence that conflicted with Keyes' hypothesis, there was only one solution: they had to be hidden. So the first of these trials was the Minnesota coronary experiment, which was done by Ivan France Jr. Interestingly, Keyes was the premier researcher, but his name doesn't appear here, which is really interesting. But he drew up the trial, and he raised the funds for it, but his name doesn't appear. And that's something that I've never understood why that should be. This study was completed in 1976, and the data were presented at a cardiological conference, presumably the American Cardiological Society, in 1976. But the data were only published in 1989. And remember, 1976 was 1 year before the McGovern Commission released its findings. So the question is, what was the impact of this study not being published in 1976 and only being published in 1989? So here was the trial: a large number of men and women living in Minnesota mental institutions. Half were assigned to a diet with reduced content of saturated fat, and the other half were assigned to the diet with the same total fat but with more saturated fat. Now notice, this is not a low-fat diet. This is a diet high in polyunsaturated fats, and this was therefore not a study of the low-fat diet, which was the one that we're told to eat. This was of replacing saturated fat with polyunsaturated fats. Subtle but important point. So here is the intervention diet and the control diet, and they had the same amount of total fat, but much less saturated fat in the intervention, much more polyunsaturated fats, pretty much the same monounsaturated fats, and much less cholesterol. And so this trial then went for about 5 years, and the subjects were followed for 4.5 years, and then the results were reported. But the data were known in 1976, but they only get reported in 1989. And here was the graph published in 1989, and you can see on the left is the percent of subjects, both men and women, without events, and you can see it looks pretty much the same. But on the right is a survival curve, and if you look carefully, you'll notice that the survival curve for the control group is better. And so at the end of the experiment, there are more people alive on the control diet than in the treatment diet, and the change seems to occur after about 1.5 years. That's where the two lines start to differentiate. And remarkably, there were more deaths in the treatment group than in the control group. So anyone looking at this graph, as I've shown it to you there, would have to say these are not equivalents. The treatment group are doing worse than the control group. But that was not how it was reported. And it said, although the study did not show a statistically significant reduction in cardiovascular events or total deaths from the treatment diet. Now, why would you say that first? Why would you say, although it didn't? Why wouldn't you just say these are the results? But they don't. And that's the problem with all these diet studies. They're trying to make sure that they always prove that the diet works. So therefore, if it doesn't work, it's a surprise. So then the authors suspect that it might have shown such a reduction if the period of treatment had been longer in persons in the age range likely to benefit. We included persons of all ages, both men and women, with an average cholesterol concentration of 207 milligrams per deciliter compared to much higher values in other clinical trials. So what you notice in all these trials is that the authors will always tell you why the study didn't find what it was expected to find, but that is not science. Science is you test an hypothesis. If the data don't fit the hypothesis is wrong, and you start all over again with a new hypothesis. But I'll show you this is something that these researchers could never do because their funding was so dependent on them finding for the diet and then continuing the funding sources, because anyone who found opposite to that would lose their funding. So there's no way they were going to chance their careers and end their careers by finding in favor of a diet higher in saturated fat. Well, eventually Dr. France died, and his son, who's a medical doctor, was going through his house, his father's house, and discovered all the records from the Minnesota coronary experiment. And he decided to get in touch with Dr. Ramsden, who he knew could analyze the data, and he sent them to Dr. Ramsden. And then Dr. Ramsden went through them and produced the recovered Minnesota coronary experiment data. But this was what the interview Anna O'Connor wrote at that time in 2016 when the data were first reported. So what was the result? Despite being one of the largest controlled clinical dietary trials of its kind ever conducted, the data were never fully analyzed, and that's absolutely true. It was a brilliant study. It was very well conducted. The younger Dr. France said his father was probably startled by what seemed to be no benefit in replacing saturated fat with vegetable oil. When it turned out that it didn't reduce risk, it was quite puzzling, he said, and since it was effective in lowering cholesterol, it was weird. Well, it was only weird according to the model that predicts that cholesterol causes heart disease by saturated fat causes heart disease by raising blood cholesterol concentrations. That's the only model in which it's weird. If you're a proper scientist, when you see something as weird, you say, well, the hypothesis is wrong, we have to change it. One would expect that the more you load the cholesterol, the better outcome, Dr. Ramsden said, but in this case the opposite association was found. The greater degree of cholesterol lowering was associated with a higher rather than a lower risk of death. And he then published, Dr. Ramsden published the Minnesota coronary experiment, the recovered Minnesota coronary experiment, and here was the major finding of that study, that if you were over 65 years, you did much worse if you were on the diet. And so you can see the cumulative proportion of deaths was increased in the linoleic acid group compared to the control group. And so he concluded, or they concluded, the intervention group had a significant reduction in serum cholesterol concentrations. They dropped 14% versus only 1% in the controls. Then Kaplan-Mayo graph showed no mortality benefit for the intervention group in the full randomized cohort or for any prescribed subgroup. However, there was a 22% higher risk of death for each 0.78 millimole per liter reduction in serum cholesterol. In other words, the more the cholesterol fell, the worse the outcome. There was no evidence of benefit in the intervention group for coronary atherosclerosis or myocardial infarctions. So that was the Keys study, the Minnesota coronary experiment. The data, as I've said, should have been published in 1976. They were only published in 1989, which was long after the dietary guidelines had changed the guidelines and said we should eat more polyunsaturated fats. And the point is, as in an interview Daisy Zamora said, if this study had been published in 1976 when it should have been, i.e. 1 year before the Dietary Guidelines Committee of Senator McGovern had come up with the new guidelines, they couldn't have produced those guidelines. Because people would have said, but hold on, you've done a clinical trial, it disproves your hypothesis, how can you now force the Americans to change their diets on the basis of a diet which we now causes harm? It couldn't have happened. So that's why this study was so important that it should be suppressed. So he further concluded, Dr. Ramsden then went and looked at all the studies of polyunsaturated fat substitution for saturated fats, and he said the available evidence from randomized controlled trials shows that replacement of saturated fat in the diet with the linoleic acid effectively lowers serum cholesterol, but does not support the hypothesis that this translates to a lower risk of death from coronary heart disease or all causes. And then he warns that findings from the Minnesota coronary experiment add to growing evidence that incomplete publication has contributed to overestimation of the benefits of replacing saturated fat with vegetable oils rich in linoleic acid. I would say it's worse. It's not just an overestimation of the benefits, it's an exclusion of the evidence for harm caused by this substitution. So the next study to be recovered was the Sydney Diet Heart study, which was started in 1966, and the early publication came out in the 70s. And here's, of course, the Sydney Opera House, and it says here the Sydney Diet Heart study ended in 1973, the same year when the Opera House was opened. And then it took another 40 years before the real evidence from the study was published, and again it was the recovered Sydney Diet Heart study. So here's the original study. 458 Sydney men, middle-aged men with heart attacks, were randomized. Half were assigned to a reduced saturated fat diet and half were assigned to a self-selected dietary behavior. They basically could just continue to do what they like. And the intervention group replaced dietary saturated fat from animal fats, common margarines and shortenings with omega-6 linoleic acid from safflower oil and safflower oil margarine. So again, this is not a low-fat diet study. It's a study of replacing saturated fat with polyunsaturated fats. The control group were just told to keep eating, but they could replace butter with margarine if they so wished, which is interesting because that shows that there was already accumulating pressure for people to eat margarine instead of butter. and they were studied for 2 to 7 years. And here's the paper of the outcome, and it's published in 1978. There we have it, published 1978. And this is the conclusion. Survival was slightly better in the second group. Now that's really interesting, because which was the second group? It was the control group. He didn't say survival was slightly better in the control group, because that you'd have to read the article to know which was the second group. But if it said control group, then everyone would have known. Multivariate analysis showed that none of the dietary factors were significantly related to survival. Prognosis was determined largely by the extent of coronary and myocardial disease, as judged by the usual clinical parameters. Recreational physical activity had a strongly favorable influence on survival, and I'd argue that's probably associational. In other words, the healthy people are the ones who are more likely to survive and more likely to be exercising. It is concluded that because of multiple changes in lifestyle, men who have had myocardial infarction are not a good choice for testing the lipid hypothesis. And they explained because weight loss, reduction in cigarette smoking, increases in physical activity, and other readjustments may well have more important beneficial effects than changes in dietary lipids. So again, it's another explanation why they didn't find what they wanted to find. Well, here are the data. So this comes from the original article in 1978, and it shows that survival in the control group is somewhat better than in the intervention group. And here's the problem. There were 28 deaths in the control group, but 37 deaths in the experimental group. So that may or may not be significant, but it has to mean something. That there's clearly no benefit in this diet, and there may well be harm. Well, the harm was eventually identified by Christopher Ramsden and his team, who did the same on this study as they did on the Minnesota coronary experiment. And they produced then 3 graphs of comparing the intervention versus the control group survivals for all cause. That's all cause death rates, and you'll see the death rates are higher in the intervention group. Cardiovascular disease, cumulative death rates, again, they're higher in the intervention group. And coronary heart disease, cumulative death rates, again, higher in the intervention groups. So far from showing that there's no difference in the trials, this actually again showed that the polyunsaturated fats were harming the patients. And here with increased risk, if you were taking the intervention, 62%, 70%, and 4% increased risk. The risk is not great, again, because the risk is relatively small. So a large increase in risk doesn't actually reflect much change in risk to the individual. So Ramsden concluded, in this cohort, substituting dietary linoleic acid in place of saturated fat increased the rates of death from all causes, coronary heart disease, and cardiovascular disease. And then he included an updated meta-analysis of linoleic acid intervention trials showed no evidence of cardiovascular benefit. These findings could have important implications for worldwide dietary advice to substitute omega-6 linoleic acid or polyunsaturated fats in general for saturated fats. And that evidence has not been acted on. We still get the advice that we must replace saturated fat with polyunsaturated fats. But the trials which were meant to prove it proved the opposite, yet the public isn't told it. Then the third study, which is important, is the Women's Health Initiative, randomized controlled dietary modification trial between 1993 and 2005. And again, I'll show you that this was a very expensive study. This was the study that was going to prove that the low-fat diet prevents coronary heart disease, apart from many other things. It was going to be the Nobel Prize-winning study, and it was the final answer that the National Institute of Health and the American Heart Association were going to prove that they'd failed. The other studies had failed because they hadn't done enough. They hadn't have enough subjects, and they hadn't done a good enough intervention. So here was this trial. Listen to it, 48,000 postmenopausal women, 40 assigned to a low-fat eating plan, and 60% were just allowed to continue eating what they chose. The 40% now reduced their fat consumption from 20% and from saturated fat to 7%, and they increased fruit and vegetable intake to at least 5 servings per day and grains to at least 6 servings per day. So this was a test of the American Heart Association Heart Healthy Prudent Diet. Very important to remember that. This is a test of the diet that heart disease patients are told to eat. And it's a modern study, 1993. A lot of the complaints about the other studies that they were dated, but this is a modern study. So the poor old control group were just told to read the dietary guidelines for Americans as well as other health-related material. They had no contact with anyone, whereas this group had sometimes monthly interventions. So can you imagine organizing monthly interventions for all these people over a period of time? And then they were studied for 8.1 years. So this is an incredible study. It's unbelievable. If anything is going to prove one way or the other what the outcome is going to be, it's this study. So here's the study reported by Dr. Howard in 2005. And the conclusion was that the study did not significantly reduce the risk of CHD, stroke, or cardiovascular disease in postmenopausal women and achieved only modest effects on cardiovascular risk factors, suggesting that more focused diet and lifestyle interventions may be needed to improve risk factors and reduce CVD risk. Or perhaps what the authors couldn't consider was that the intervention is simply ineffective because it's based on the wrong hypothesis. So one of the main organizers of this was Dr. Jacques Rousseau, and his comment was, "This study shows that just reducing total fat does not go far enough to have an impact on heart disease risk. While the participants' overall change in LDL bad cholesterol was small, we saw trends towards greater reduction in cholesterol and heart disease in women eating less saturated and trans fats." So this is a post hoc justification for why the study didn't prove what you wanted to prove. But actually, Professor Rousseau, you don't understand. If you understand the null hypothesis, you'll acknowledge that your team spent $700 million disproving the diet-hard hypothesis. Trying to justify that your study would have found in favor of the low-fat diet if only you'd spent another $700 million forcing your study subject to eat a zero-fat diet is post hoc reasoning. Proper scientists understand that the best approach to a study that disproves your own long-held beliefs is to acknowledge that you are wrong. And that, unfortunately, is something that's not possible for most of the people involved in these studies. The head of the National Institute of Health at that time, Professor Nabel, added her story. "The results of the study do not change established recommendations on disease prevention. Women should continue to work with their doctors to reduce their risk for heart disease, including following a diet low in saturated fat, trans fats, and cholesterol." Which is utterly astonishing. They might as well not have done the study, because the study is not hypothesis testing, it's purely used to advertise the low-fat diet. And what I've learned from reading these people's stories is that they will always, when they present the information, they will give the impression that the study worked. And they'll never say, actually, we were completely wrong. So actually, no, Drs. Nabel and Rousseau, the study disproved your null hypothesis. In real science, when the hypothesis is disproven, we have to come up with a new one and then attempt to disprove it. Science does not prove hypotheses. What I discovered in my debate with Professor Rousseau, the week before I had the debate, I was directed to the key to his study by Dr. Andreas Ehrenfeld, who's of course so well known as the diet doctor. And he said, "Did you see this statement hidden in the middle of the article?" And it says the hazard ratio for the 3.4% of the women in the study with cardiovascular disease at baseline was 1.26. What that means is that the risk of having a subsequent cardiovascular event, if you started the study with heart disease, was 1.26, was 26% higher if you were on the intervention diet. So the intervention diet caused harm to those people the women who started the trial with heart disease. And that's exactly what you would expect. If the diet is harmful, it's going to harm the people who are most at risk. And those who are most at risk are those who have already established heart disease. So if the study had included, let's say, 20% of people with established coronary heart disease, then you might well have found that the diet was harmful, and it would have been more obvious and they couldn't have hidden it. So it's entirely predictable, as the high carbohydrate diet produces all the things we know: hyperinsulinemia, hyperglycemia, and hypertriglyceridemia in those who are metabolically vulnerable, as they are insulin resistant. So this is the canary in the mine, that the canary dies from carbon monoxide poisoning before the humans die. And these were the people who were most likely at risk. So I went then to look at the data, and what I discovered was, if you looked at this particular table, there was an anomaly on it. So generally, if we look very carefully here, we'll see this is people taking statins, and it says statin use no or yes, and then it says there was no difference. It didn't favor the intervention or didn't favor the comparison whether or not you took statins. So let's look at this. This would be yes, I'm taking statins, and it didn't favor the intervention, which was taking statins. So there was no benefit for taking statins. But that's not the point, because when we look at the diet in those people who had heart disease, we notice an anomaly. And the anomaly is that when we look to the left of the slide, we see a no, but there's no yes. So in other words, there's no report of what happened to those people with cardiovascular disease who had a history of cardiovascular disease and were on the intervention. It's not included. And then we look to the right and we notice that this dot is sitting here when it should be lower down. So there's something wrong. There's a line of text that is missing. And this is what's missing. The missing is the yes. And what happens is then you'll see, if you were on the diet, that's this dot now comes down here, and it favors the comparison. In other words, those people who were with a heart disease and who were not taking the diet. They were the control group. So in other words, if you had a history of cardiovascular disease, yes, and you were on the control diet, you did better than if you were on the intervention diet. Now that was missing from the data, and I pointed that out to Professor Rousseau in this article and suggested that he should change that and update that article. But that's not happened, and this is now 15 years after that publication. But it didn't end there, because the low-fat diet was also prescribed for people with diabetes on the trial, and it found that women with diabetes at baseline did experience adverse glycemic effects of the low-fat diet, which indicated that caution should be exercised in recommending a reduction in overall dietary fat in women with diabetes unless accompanied by additional recommendations to guide carbohydrate intake. And that's nonsense, absolute nonsense. What they should have said was that women with diabetes at baseline need to be warned that if they replace dietary fat with carbohydrates, their diabetes will worsen. So why can we not tell them the truth without such circumlocution? How could your conventional advice possibly be wrong? And that was the reality. They wouldn't admit that the conventional advice was wrong. So the Women's Health Initiative proved that if you were sick because you had heart disease or diabetes, and therefore you were the canary in the coal mine, you are at much worse risk if you followed this diet. And no one ever reports that data. So let's move on to point 6. And this is another important point that people are never told. That 2 famous studies, the 7-country study and the Framingham Heart study, failed to find any relationship between diet and blood cholesterol concentrations. And that's pivotal to the whole argument. So by failing to find that relationship, these 2 major studies disprove the diet-hard hypothesis. So let's recall this was the original Keys data in orange, and the other countries which weren't included are there as well. Now Keys then decided to go and study 7 countries in more detail, and he chose those 5 countries, and he included 2 others, Greece and Yugoslavia, for a major study in which he looked at 12,000 people in those countries, measured their rates of heart disease, what they ate, and what their blood cholesterol concentrations were. And these were the 7 countries that were studied, and the dots, individual dots, would indicate that there were 5 different communities in Yugoslavia, 3 in Italy, 2 in Greece that were studied, and 2 in Japan, and 1 in the USA. So these countries were then studied to try to prop up the Keys, or prove the Keys hypothesis. And let's recall that now what he was saying was, if I study the fat intake in 12,000 people and I measure their cholesterol levels and I check what the rates of heart disease are, then I've been able to prove my hypothesis. Now, what no one has ever told you, probably, is that this is the 3 pillars of the evidence on which Keys's twin hypotheses are based. And they're a relationship between a diet rich in saturated fat and cholesterol, that is A, an elevated blood cholesterol concentration, that is B, and the presence of coronary heart disease. Now, whereas it's quite easy to do ward studies to show that diets rich in saturated fat and cholesterol cause elevated blood cholesterol concentrations, that's a nice experiment, and it can be easily shown, and we'd have to accept those findings. These associational studies are hypothetical because we don't know that that is actually what's causing that the elevated blood cholesterol concentration is definitely causing coronary heart disease, because as others have argued, there could be many other factors. Similarly, this is an associational relationship of diet rich in saturated fat and cholesterol and heart disease. For example, if we go back to Keys' original study, his argument would be that the Americans, I should say, have a diet high in saturated fat, and that's why they have heart disease, whereas the Japanese have a diet low in saturated fat, and that's what they have low heart disease rates. But to think that there's nothing else different in the lifestyles and everything else that goes into making heart disease between the Japanese and Americans is ridiculous. So that's an associational study. Now, what Keys has been very good at doing is whenever they find that there is an associational relationship, they will trumpet that finding. But those findings are irrelevant if the diet doesn't cause the blood cholesterol to rise. That has to be the key. If you can't prove this relationship in these populations, then the other relationships are null and void. They're irrelevant. And so that's the point that I'm making here. That if in his studies he couldn't show that the diet caused the elevated blood cholesterol concentration, then everything else was moot and irrelevant. So here's one graph from one of his acolytes, Dr. Daniel Steinberg, who here's the data from those countries, and there's a lovely relationship between the median cholesterol concentration and the 10-year coronary deaths. Now remember, this is an associational relationship. He also showed an associational relationship between saturated fat in the diet and the 10-year coronary deaths, but it's not quite as clean. As you can see, there are some outliers that don't fit the pattern. And in fact, when other people, Smith and Pinckney, went and looked at all the data from all the communities and linked and listed on the basis of the percentage calories of saturated fat, going from 22% in East Finland to 3% in Tanushimaru, you'll see that the CHD rates weren't just a direct relationship. And all-cause mortality was also not as clearly related. There were countries that stood out, like here, the United States stands out, and this country stands out as having a very, very low, much lower than expected. And so when it was analyzed further, they noticed that there were these differences. So all these communities were eating the same amount of saturated fat by percentage. Their CHD death rates differ dramatically. So here, look at this one, but between Monte Giorgio and Crete, very big differences there. And then this was the same, that there was a small difference in saturated fat consumption of 1%, but large differences in coronary death rates. So very, very dubious. The relationship might, in the overall group, the relationship might be there, but when you took individual communities, you could see that it all broke down completely. And so therefore you can't have an hypothesis which is disproved by this sort of analysis. But so now, as we're reading through Dr. Steinberg's article, we're looking for the third relationship, because he's shown us this relationship, he's shown us this relationship, but he hasn't shown us this relationship in the 7-country study. Where is this relationship? So I provided it for you. So here are the data from the 7-country study showing the relationship between the percentage dietary calories from saturated fat and the 10-year mean blood cholesterol concentrations. And oops, sorry folks, you can't see these data, because the data showed that there was no relationship. There was no relationship. So the basis for the triangulation of effects is not there. Therefore, the other effects are mute, they're irrelevant. So the study showed, the hidden finding of the 7-country study was that individual serum cholesterol concentrations were unrelated to the composition of the diet. And that you can download from the internet from this article if you want to check it. And when you read the article, you'll see how they tried to circumlocute that and say what the reasons why they couldn't find this relationship. But if the relationship is not there, then it is not there, and it's time that people understood that. Now, the other very important study, which shows exactly the same finding, is the Framingham Heart Study. And I've got at great length in my CrossFit columns gone into the Framingham study to show you what it did and what it didn't show. But what it did show, which was also never reported because it was hidden, was that there was no relationship between individual diet and individual blood cholesterol concentrations in this population. And this was eventually acknowledged. And here's an article on October 30th, 1970 in the news, the Framingham Natick News, 1970. And remember, the Framingham study hadn't been going long when this was found. And so this is the person, George Mann, who was directly involved in the study, but who resigned eventually because he realized it was a scam and that the important data was being hidden. So detailed medical histories were recorded on a subsample of about 1,000 subjects in the Framingham study by Miss Georgiana Pearson. She did 3 years spent interviewing these people. It was a meticulous enterprise. The data clearly showed no relationship between dietary intakes of either fat or cholesterol and the subject's level of cholesterolemia or their experience of coronary heart disease. So there you go. The Framingham study disproves the Keyes hypothesis, but you will never, ever, ever hear that statement. These dietary data were never properly published because the findings were contrary to the position held by the National Heart, Lung and Blood Institute. That's the organization that runs the Framingham study. To withhold that information is a form of cheating. Nevertheless, the Framingham study, now a 40-year longitudinal study of risk factors for CHD, has failed to show that any measured dietary behavior is a risk factor for coronary heart disease. These dietary data were never properly published because the findings were contrary. And, when he made that comment, this went over like a wet blanket with my superiors at the National Institute of Health because it was so contrary to what they wanted to find. They wouldn't allow us to publish the data. And they went and hid the data in one of the NIH buildings in Washington, D.C., and they were only recovered many years later to show that this relationship didn't exist. And if you read this article, the findings of the Framingham Diet Heart Study, you'll see that they acknowledge that finding. Now, it's also we're often told that the Framingham study clearly showed that cholesterol is a major risk factor for heart disease. Well, this is their 20-year data for the relationship between low, average, and high blood cholesterol concentrations and percentage who would develop heart disease. And you'll see that if you have a normal cholesterol, your probability of developing heart disease is about 10%. If you have it elevated, it's about 18%. So that's an 8% increase over 20 years, which means an 0.4% increase per annum. So that tells us if we want to protect one heart attack per year, we have to treat 250 patients. We have to reduce their cholesterol from that value to 250 patients for one to benefit. So that clearly never showed that there was a tight relationship with cholesterol and heart disease in the population in Framingham, and we also know that the diet wasn't a factor. Interestingly, the Framingham study eventually began to question LDL cholesterol as a significant risk factor when they started to measure HDL cholesterol. And already by the mid-1970s, the researchers led by Cannell and Gordon were saying, actually, we got it wrong, that HDL is a protective factor and LDL is causative. So here we have a relative risk for people with different HDL values and compared to their LDL values. So on the left are people with low LDL cholesterol concentrations, and you'll see that as we move to moderate or so-called elevated cholesterol concentrations, if you have a low HDL, you'll see that the risk rises, whereas if you have a high HDL cholesterol concentration, the risk rises very little, and the intermediate values are intermediate. So they then begin to realize that actually it's not the LDL that's the key factor in this. The HDL is protective, or that's how they saw it. They then started publishing these sorts of graphs, and here we're relating the LDL cholesterol concentration, or the total cholesterol concentration, which I'm showing here on the x-axis, and on the y-axis, as it were, this is the HDL cholesterol, and it's increasing HDL concentrations from left to right, and it's increasing cholesterol concentrations from left to right. And we always start with the highest columns, and the highest columns occur in those people who have normal to elevated total cholesterol concentrations. So that's the relationship there. And you'll see that even if you have a low HDL cholesterol concentration, it doesn't matter what your cholesterol is, your risk is high. But as we move to the right, as the LDL cholesterol rises, the HDL cholesterol the risk for heart attack is zero. It's not increased. I'm just confused. I apologize. These figures, the numbers are wrong here. What's happened is they've just been repeated from there, and I've not checked it before. So you'll just have to believe me that these are low total cholesterol, and that's high total cholesterol. So what it shows is as your HDL cholesterol rises, your risk of heart disease goes down. And the best group doesn't matter if you've got a high or low total cholesterol, your HDL cholesterol will be protective. And then here's another graph, which here we've got the cholesterol values are correct. And so if you're concerned, those would be the same values from the previous slide. This is a later study. It shows exactly the same. To repeat, if you have a low HDL cholesterol at any total cholesterol value, your risk is high. At a high HDL, the cholesterol value makes no difference. They then went further and said, right, what happens if you have triglyceride values which are either low, medium, or high, and you have low HDL, medium HDL, or high HDL cholesterol? And what they show that there is an interrelationship, so that it's very best to have low triglycerides, low or medium triglycerides with high HDL cholesterol. And the point here is that there's no one in this group who has a high HDL cholesterol who also had high triglycerides. And so that's the point. That indicates, all of you will know, that people in this group are highly insulin sensitive because they have high, they wouldn't be. They wouldn't exist because you can't have high triglycerides and high HDL. Doesn't exist. And similarly, you can't have a low HDL and low triglycerides. They don't fit either. So this is a complex slide, but it shows that triglycerides influence the outcomes as well. And so they were slowly moving towards understanding that, in fact, to determine risk, you have to look at both HDL and triglyceride concentrations. Now, the final study that has really put it all together is the insulin resistance study in the Framingham offspring. These are the children of the original Framingham cohort. And they were studied for the relationship between insulin resistance and dyslipidemia and coronary heart disease. And this is what they showed, and it's rather complex, so we'll go through it clear differently. So in each group, they divided them into 4 different groups. And then this is the cumulative incidence of coronary heart disease events. Now, they've divided the people on the basis of their HDL cholesterol concentration on the left and the level of insulin resistance. And on the right, it's the triglycerides and the level of insulin resistance. And what they show, if you have a low HDL cholesterol and your insulin resistance, your risk is extremely high. Whereas if you have a high HDL cholesterol and you, on other tests, you're not insulin resistant, so you have a low fasting insulin and low fasting glucose, you would then be at very low risk. And you can see the difference is enormous. It's a 6-fold difference at least. So this group is insulin sensitive with high HDLs, and they are protected. And on the right graphs, we see the same, that if your triglycerides are high and you're insulin resistant, then your risk is high. Where if your triglycerides are low and you're not insulin resistant, your risk is again about 1/6 of the risk of the insulin resistant person who's eating a high carbohydrate diet and therefore has high triglycerides. So their conclusion that in this community-based sample exclusive of diabetes, incident cardiovascular heart disease risk associated with plasma HDL cholesterol or triglycerides was significantly increased only in the presence of insulin resistance. So this really shows that the Framingham heart study ultimately showed that it's insulin resistance which increases your risk of coronary heart disease. And the original idea that it was cholesterol alone that was causative, or it was HDL that was protective, has now been sorted out. And it's the insulin resistance that is the problem. So we move on to point 7. And this is a point that's very seldom reported or taught to medical students or dietitians. And it's the report from the Mr. Fit trial, which was one of the largest trials ever of reversal or changing coronary risk factors to see what the outcomes were. And of course, the reasons we aren't talked about it is because it didn't work. So Mr. Fit proves that reversal of all the major coronary risk factors, and I put the risk factors in inverted commas, because we just assume that they're risk factors. We're told that so often, we don't question, including the use of a low-fat diet, has no impact on longevity or mortality. So Mr. Fit stands for Multiple Risk Factor Intervention Trial, and this was the protocol that was followed. 360,000 middle-aged men were screened for cholesterol and other risk factors, smoking, hypertension, and so on. And the 12,000 with the highest risk factors were selected. So this was the sickest of the sick. There couldn't be any more ill people, potentially ill people, than were included in this trial. And half of them were put on a prudent diet. They reduced their cholesterol, saturated fat, and total calorie intake, and they ate more vegetables and polyunsaturated fat, whereas the control group just ate their usual diet. And the effect of this trial was remarkable, and I didn't realize how effective the intervention was in terms of changing risk factors. So this is Thomas Moore's book, is one of the three that I always prescribe to people. The other two, of course, are Nina Teicholz's book and Gary Taubes' book. But this was the original book, which looked at the early studies trying to link diet to heart disease and showing that there just was no evidence at all. So he describes how the results of this dietary intervention were extraordinary. Subjects reduced their cholesterol intakes by 42%, saturated fat intakes by 28%, and total calorie consumption by 21%. These outcomes have not been matched by any subsequent intervention. So if you wanted a real dietary intervention that worked, this was it. Using every technique then available, including monetary rewards, marathon group sessions lasting 2 to 3 days, during which subjects attempted to avoid smoking. Also the use of hypnosis and aversion therapy supported by continual monitoring by the interventionist, the number of smokers in the intervention group fell by 50%. And then there were remarkable changes in abnormal blood pressures. 87% of hypertensive subjects reduced their blood pressures to below the threshold defining moderate hypertension, and 67% reducing their blood pressures to the normal range. So there's no trial that could have produced better outcomes in terms of reducing coronary risk factors. So you would imagine that this must have a huge effect on subsequent incidence of heart disease and mortality. So let's see what happened. Blood cholesterol concentrations fell in both groups because the control group also were rather good at lowering their cholesterol. They reduced their smoking, and their hypertension was also quite well reduced in the control diet. After 7 years, 265 died in the treatment group. So clearly they're going to have to be more in the intervention group, but there weren't. There were 260 died in the control group. And the major conclusion from this study was that the cessation of smoking was the only intervention that influenced the outcome. So the conclusion of this multi-billion-dollar study was it's a good idea to stop smoking. And the other risk factors didn't seem to have any impact on subsequent risk. Now, it's obvious that lowering blood pressure, particularly if you don't use medication, must reduce risk. And the same with smoking, it must reduce risk. So the question is, well, did something else that the group did harm them? Was it the dietary change that harmed them and prevented any benefit from being shown by the reduction in smoking and the reduction in hypertension? When I looked through the data, it's really interesting that to show that the cholesterol values in this study, and we'll come back to that, they didn't really show much increase in risk. So in other words, if you look at this, these are the highest values compared to the lowest values. You'd say, gosh, well, that's quite a big increase in risk from say 15 up to about 40 units. But then you look at the units and it's per 10,000. And that's so that this is a minuscule increase in risk, which we'll come back to. But what does increase risk is having diabetes. That's clearly what makes a difference. And so if you have a high cholesterol and you have diabetes, then your risk is about threefold greater. Whereas if you don't have diabetes, raising cholesterol increases your risk, let's say twofold. But you must remember that the risk is low, so doubling of risk is small. So even trebling risk is quite small. Nevertheless, it's very clear that diabetes produces more risk in this trial than does an elevated cholesterol concentration. Now, these data were published by Stamler and Cannell, and Stamler and Cannell were both involved in the Framingham study, and they inherited the Mr. Fit trial as well, and they were very strongly committed to cholesterol being the major risk factor for heart disease. So when they looked at the Mr. Fit data, they produced this graph which suggests that risk rises and CHD deaths also rise. Sorry, total deaths increase and CHD deaths also increase with increasing cholesterol concentrations. The only problem was that they used unequal interval scale. So here they lumped everyone below 182. This group had a range of about 20 milligrams per 100 ml. This was also about 20. This was also about 20. But here there was an unequal distribution because this included many people with very high values. But what was of much more interest was the data was subsequently reanalyzed, and people questioned what's going on at the low level of cholesterol. And ESO published this data in the New England Journal of Medicine 3 years later. And ESO was independent. He hadn't been involved in the other trials. He hadn't been involved in the Framingham study. And see what he noticed. He noticed that total deaths actually rose at low cholesterol. So Stamler and Cannell had collapsed these data into this point here, and so they had avoided the identification that low cholesterol was as dangerous and as high cholesterol in this group. And the same for CHD deaths. Actually, there was no difference. That didn't seem to make a difference. So at low cholesterol, there was clear evidence that total deaths were increased, but Stamler and Cannell chose to hide that fact. The next person who used this information was Scott Grundy, who was one of the first people to start promoting statin use. And so he was very biased towards the idea that cholesterol levels are important. So he published this important and influential paper in 1986, and it's essentially the same data. Here's the mortality rate, and it seems to be going up very, very steeply. And then he looked at the CHD risk, and you'll see here the risk for a high cholesterol is fourfold a low cholesterol. So that was the message that was spread around the world, that an elevated cholesterol risk increases your risk fourfold. But the question is, well, what does that really mean? Because again, no one noticed that this is per 1,000 patients. And so the annual death rate for people with a low cholesterol was 0.25%, and for a high cholesterol was 1.35%. So this fourfold increase really was of no particular consequence to anyone with a high or low cholesterol. For the simple reason that even if you increase risk fourfold, from a low risk it went up to a slightly less of a low risk. But Grundy used this information to startle the world, and which was very convenient because in 1986 was just before the statin drugs were about to be released. And so this paper caused the population to begin to believe that it was very important that you should lower blood cholesterol concentrations. So there's the risk fourfold. And then what he next did was to draw the same graph as he has the coronary heart disease risk on the right side, and there it goes, as he's indicated, goes from naught risk if your cholesterol is low, which of course is wrong because that may be coronary heart disease, but all-cause mortality is going up at this end. But he conveniently ignored all-cause mortality, as they tend to do. And so he said here, when you are with a cholesterol of 7,76 millimoles per liter, or 300 milligrams per deciliter, guess what? 100% of your coronary artery surface area has atherosclerosis. So that's the graph. There you go. From these data of cholesterol levels and a small increase in risk, he says the problem is, as your cholesterol goes up, your coronary atherosclerosis goes up. And so that once your cholesterol is 300, you got 100% atherosclerosis, which is nonsensical. That's never been shown. But again, this is what was allowed to be spoken about and promoted in the 1980s because of the fear of cholesterol and the knowledge that statins were about just around the corner. So next point, point 8, is quite interesting. I've called it the big Harvard bribe of 1965. And this came to the fore only a few years ago. And here was a report of this paper. So sugar papers reveal industry's role in shifting national heart disease focus to saturated fat. And the paper that is referred to is by Kearns, Schmidt and Glantz, and the title is Sugar Industry and Coronary Heart Disease Research, a Historical Analysis of Internal Industry Documents. And the story is that on the 1st of July 1965, the vice president of the Sugar Research Foundation in the United States paid a courtesy call to the Harvard Medical School, particularly the nutrition division, where he met with one or two of the professors there, and he, in his baggage that he carried with him, were 4 articles that had just been published in the Annals of Internal Medicine in the June 1965 issue of the Annals of Internal Medicine. And his concern was that these 4 articles seemed to suggest that carbohydrates and sugar were detrimental to cardiovascular health. So remember, this is 1965. Keyes' hypothesis has been around since 1953, but there's plenty of interest in the role of carbohydrates causing hypertriglyceridemia, which may also be related to coronary artery disease. So the first of these 4 papers was by Ostrander and colleagues, and they reported that an elevated blood glucose concentration, even in the absence of diabetes, was at least as good a predictor of future CHD risk as was the blood cholesterol concentration. The second paper was by Frederick Epstein, who interestingly was one of Keyes' premier acolytes and who became one of his greatest supporters. But clearly in 1965 he wasn't quite so convinced. And he was involved in the very famous Tecumseh study, which is an epidemiological study of an entire population. And they also showed in the Tecumseh study that there was no relationship between the diet and blood cholesterol concentrations in that population. And that's one of about 20 or 30 studies showing exactly the same thing. But what they did find was that the presence of type 2 diabetes predicted more severe disease in all the arteries throughout the body, not just in the coronary arteries. Thus, the detection of hyperglycemia with significant frequency among persons with each of 5 different manifestations of atherosclerotic vascular disease is a unique finding amongst epidemiological studies. So they were taking the relationship of diabetes beyond just the coronary arteries. Then the third paper was by Peter Q and David Bassett. And Q had been one of the finders of this carbohydrate-induced hypertriglyceridemia, and now he looked at the role of sugar in producing hypertriglyceridemia, not just carbohydrates. So he'd already linked carbohydrates to hypertriglyceridemia. Now he looked at sugar, and he found that the data indicate that sugar is a potent lipemic agent as compared with starches. and a high dietary sugar intake may well be the most important factor in the production of the clinically encountered type of hyperglyceridemia. And here's his graph or his data showing that in a group of people, when they ate their self-selected diet or they ate the sugar diet with carbohydrate as sugar, their triglycerides, phospholipids, and cholesterol all increased. However, once they replaced the carbohydrate from sugar as starch, all of the values fell again. But when they reintroduced sugar, all the values rose again, and it repeated as they removed the sugar and replaced it with starch. Down went the values again. So that was fairly good evidence that sugar was causing hypertriglyceridemia, whereas starch seemed to be protective. That's a really interesting point that perhaps we haven't mentioned as much, that starch has a quite different effect than sugar on blood triglyceride concentrations. And the final article was an editorial by Margaret Albrink, who was one of the first persons to say that triglycerides are an important cause of coronary heart disease. And she said that she then looked at the biological evidence that humans had humans had evolved eating a high-fat diets. And she said the data are consistent with the hypothesis that the common modern diseases of diabetes, atherosclerosis, and obesity and associated hypertriglyceridemia may be the present-day manifestations of the effect of affluence on a once useful genetic trait, the ability to conserve carbohydrate. And the trait that she's talking about, if you look at it carefully, was insulin resistance. So what she's saying is that insulin resistance is the underlying cause for modern diseases, diabetes, atherosclerosis, and obesity, and hypertriglyceridemia, and that they are manifest in people who are insulin resistant and who are eating high carbohydrate diets. So this is another interesting paper that came out in the same time, and to which the Harvard professors, who were being encouraged to write some articles, which we'll come to, they also knew about this paper, which was then available, American Journal of Clinical Nutrition, 1966, which was a study of the relationship of fat, simple sugars, and complex sugars, and as a percentage of the calories and blood cholesterol concentrations in 16 different countries. And they showed that whereas fat caused an increase in blood cholesterol concentrations, simple sugars had a much bigger effect, whereas complex sugars caused a reduction. And this study also was causing the Harvard guys a bit of trouble as they started writing their review. So the point of showing you that is to show exactly what was going on behind the scenes. 9 months into the project, in April 1966, Hegsted, who was one of the professors at Harvard, told the Sugar Research Foundation that the review had been delayed because of new evidence linking sugar to coronary heart disease. Every time the Iowa group published a paper, we had to rework a section in rebuttal. The Iowa group was this group who reported a positive association between sugar consumption and elevated serum cholesterol levels in this epidemiological associational type study. So what this shows was that Hegsted from Harvard was biased, significantly biased, because he was writing in April 1966 he was trying to downplay the sugar link to blood cholesterol concentrations and heart disease. And he was doing that because he'd been given money by the Sugar Research Foundation to write an editorial in the New England Journal of Medicine. And one of the other people who was involved was Fred Stair, who was also one of the professors at Harvard. And he was known to be an easy catch for industry. As someone wrote an article about him, Harvard sugar-pushing nutritionist, that is Fred Stair. In all these disputes, Dr. Stair had played a Panglossian role by maintaining that DDT is harmless, sugar is good for you, and saccharin is pure pleasure and won't hurt you. And I had to look up what a definition of Panglossian is. It's someone who's marked by the view that all is the best in this best of possible worlds. Someone who's excessively optimistic. So Dr. Stair was not someone who was particularly critical. He was only too happy to promote any idea that was optimistic. So Fred Stair combined with Robert McGandy and Donald Hegstead from Harvard to write this review in the New England Journal of Medicine, Dietary Fat, Carbohydrates, and Atherosclerotic Vascular Disease, with a concluding second part. And this is what they concluded in 1967. And this was a pivotal study because in my impression or interpretation, this was the end of the debate that carbohydrates might be causing heart disease. From this moment on, carbohydrates and sugar as potential risk factors for coronary heart disease are written out of history, and it all becomes the diet-heart hypothesis and the lipid hypothesis of Ansel Keys. So the major evidence today, and that's 1967, suggests that one avenue by which diet may affect the development and progression of atherosclerosis. Sorry, there's only one avenue. This is by influencing the level of serum lipids, especially serum cholesterol, though this may take place by means of different biochemical mechanisms not yet understood. So there we go. It's only cholesterol. If you read that today, you would say, well, that's what we've been taught now for the last 50-odd years. Well, that's where it starts. There can be no doubt, and when I read that, I always say, well, therefore there's clear doubt. Because if there was no doubt, you wouldn't have to say it. So there can be no doubt. In other words, there's plenty of doubt that levels of cholesterol can be substantially modified by manipulation of the fat and cholesterol of the diet. And that is true in laboratory studies, but in the general population, the other factors that influence the serum cholesterol are much greater. They have much greater effect than diet. But this is something that is hidden, and I've given all the evidence to show that. We conclude on the basis of epidemiologic, experimental, and clinical evidence that a lowering of the proportion of dietary saturated fatty acids, increasing the proportion of polyunsaturated fatty acids, and reducing the level of dietary cholesterol are the dietary changes most likely to be of benefit. The solution here, in our opinion, is a responsibility and opportunity for the food industry, namely the manufacture of many common foods with characteristics that will lessen the development of atherosclerosis. This is possible today and only awaits leadership from the food industry. And that's quite a statement, that the food industry must lead us in developing foods that are healthy for us. Well, of course they did, and they replaced fats with sugar and refined carbohydrates and caused the obesity and diabetes epidemic. So this statement is quite important in the context of what happened subsequently. Now, he had to write out sugar and carbohydrates, these guys, so that this is what they said. Limited evidence from studies on man as well as from researchers on laboratory animals show a slightly significant role for the kind and amount of dietary carbohydrates in the regulation of serum lipids. And that's nonsense, because it's very clear that serum triglycerides are influenced most actively by the carbohydrate content of the diet. These effects are somewhat more pronounced when diets low in fat are consumed. Since diets low in fat and high in sugar are rarely taken, we conclude that the practical significance of differences in dietary carbohydrate is minimal in comparison to those related to dietary fat and cholesterol. Well, sadly, the diet that would be promoted after 1977 was low in fat and high in sugar, because once the fat was taken out of the diet, the taste went away, and the taste had to be replaced with sugar. So this is an important statement, because we now understand how incorrect it was. So we move on to the final 2 points, and these are areas I'm not competent in, so I'm just giving you the evidence as been reported in the literature. And these are areas that people might find interesting. So I've called this the big coronary artery histology fraud, and I learnt it from Vladimir Subotin, who's in remarkable shape for a man in his 60s, and as you can see, he's a champion bodybuilder, a weightlifter, general exerciser. So he's prepared to take on the world because he's got the muscles to fight it. And in his article that has been the most popular for me to read, he writes that excessive intimal hyperplasia in human coronary arteries before intimal lipid deposition is the initiation of coronary atherosclerosis and constitutes a therapeutic target. Now, here is some of the evidence which he presents, which I've called the great histology fraud. So here's a diagram, and I think this one comes from Encyclopedia Britannica, and on the left it shows a normal coronary artery, and on the right, or normal artery, and on the right it shows an artery that's invaded by coronary atherosclerosis. And so the key point is that there's an acellular space between the endothelium, which is here, and the tunica media, which is the muscular layer. And the muscular layer, as you can see, has got multiple layers of cells, muscle cells, but below the endothelium, there's no cells. So it's an acellular space. That's what the diagram says. And just to confirm that the tunica intima is the endothelium plus the subendothelial space, and the tunica media is the muscular layer. So that's what the textbooks show. And that is what is used to explain how atherosclerosis develops. In other words, the cholesterol invades, crosses the endothelium, because the endothelium becomes inflamed for some reason. The cholesterol accumulates in the subendothelial space, which is considered to be an open space just waiting for the invasion of cholesterol. So here's a diagram showing here's the endothelium, here's the subendothelial space, which is the tunica intima. There's the endothelium, here's the tunica intima. The subendothelial space, which is largely acellular according to this theory. Then you have the internal elastic lamina, and then you have the tunica media, which is the muscle cells. And here's what's going to happen, that the cholesterol is going to enter and cause the atherosclerotic plaque, and the plaque is going to progress. And again, can you see that the tunica intima is just an open space waiting to be invaded? So what Dr. Subotin did was he looked at work by Dr. Nakashima and his colleagues, where they looked at normal coronary arteries, and guess what? They found that the normal coronary arteries, the tunica intima is large. It's at least as large and as cellular as the tunica media. So here we have in all these diagrams, you can see the tunica intima is thicker than the tunica media. This is not an acellular space. And therefore the question becomes, well, how does cholesterol squeeze between these cells to cause coronary atherosclerosis? So in human coronary arteries prone to coronary atherosclerosis, the tunica intima is at least as cellular as the tunica media. So how does blood cholesterol squeeze in between, its way between these cells to initiate coronary atherosclerosis? Nakashima continued their research, and they did coronary artery histology and staining of numbers of people who had died, and they then looked at their coronary arteries to see how does the coronary atherosclerosis develop. So the top figure, the top column, the top row is of a healthy normal coronary artery. The second is one that has developed fatty streaks, and the third is grade 2 fatty streaks. And so what you see again is that the intima is thicker than the media, and the first event that occurs is that lipid starts to accumulate deep in the intima. And that progresses, as you can see here, in the fatty grade 2 fatty streak. there's more lipid, but the lipid is accumulating deep in the intima, not at the surface, which is where it should be accumulating if the cholesterol is coming directly across the endothelium. And then macrophage accumulation is also a factor in this disease, and the arrows indicate that the macrophages are pretty absent in the first 3 stages. But as the disease progresses, you can see more and more lipid accumulates, and now it starts to progress towards the luminal side of the artery, and you can see the macrophages are accumulating. So the conclusion is that atherosclerosis develops deep in the intima, not at the surface air level. And so Surboten comes up with his own hypothesis of what's happening, and again, this is hypothetical, and what he says that the cells in the tunica intima start to proliferate and grow for whatever reason. They are stimulated to grow. Ultimately, they outgrow their blood supply and they become hypoxic, and that causes the ingrowth of arteries from the vasa vasorum, and that then causes the atherosclerotic plaque. And the point of this is that there has to be a better explanation than we have if the intima is so large, and it has been ignored by histologists who have written out the fact that the tunica intima has many cells. So he concludes that the consensus hypothesis on coronary atherosclerosis suggests high LDL cholesterol levels as the major cause, and pursues it as a therapeutic target, i.e. by using statins, explicitly assuming, 1, that the tunica intima of human coronary arteries consists of only one cell layer, the endothelium, situated on a thin layer of scarcely cellular matrix, and secondly, that subendocardial lipoprotein retention initiates the disease. However, the facts that he presents show that the normal tunica intima invariably consists of multiple cellular layers, and secondly, that initial lipid depositions occurred in the deepest layers of the tunica intima. This review suggests that coronary atherosclerosis starts with pathological intimal expansion resulting in intimal hypoxia and neovascularization of adventitial vasa vasorum, facilitating lipoprotein extraction by previously avascular deep intimal tissues. And so that's the hypothesis, and my point is that it's really interesting that the conventional explanation of how coronary atherosclerosis develops has to falsify the true histology of the coronary arteries. So finally we come to point 10, which is the Kumaro model of PUFA, polyunsaturated fatty acids induced atherosclerosis. And here's Fred Kumaro, and he was the first scientist ever to raise warnings about the dangers of trans fats. So when the original polyunsaturated fatty acids were produced beginning in the 1900s by the Procter & Gamble company, they included an enormous amount of trans fats, and perhaps as much as 50% of the fats in the polyunsaturated fatty acids of margarines and hydrogenated fatty acids were consisting of trans fats. And Kumaro spent his life defending the theory that the trans fats are dangerous. And my point is that his theories are kind of ignored. We never hear about how polyunsaturated fatty acids might be linked to coronary artery disease. So the 2 articles, this is one of the first article that I followed in detail by him. And that article includes this figure, which we've already discussed before, that the consumption of animal fats fell dramatically, has fallen since the 1920s, whereas the consumption of vegetable fats has increased. And if we to overlay the incidence of coronary heart disease, we'll see that it starts to rise in the 1920s, and it peaks in the 1950s, and then it starts to fall again. And Kumarai's explanation is that the trans fats were present in the diet right up to the 1960s. And then through his work, the trans fats started to be removed from margarines and polyunsaturated fats and shortening. And he believes that the trans fats were the cause of the coronary heart disease increase. So this is the second article that he describes, and it includes his hypothesis, which again, I'm not an authority on this complex biochemistry, and I can only present to you what he's found. So one of the first points he looked at was the presence of sphingomyelin in the non-branching and branching segments of the same artery in humans, and it's well known that bifurcation points have more coronary atherosclerosis than non-branching points. So in his original study, he was able to show that sphingomyelin accumulates in the bifurcation areas of arteries prone to coronary atherosclerosis. He then was able to show that the sphingomyelin content of arteries increases with age and is greatest in arterial plaques. So in the umbilical cord of the newborn, sphingomyelin content is low, but in the arteries of people who've undergone coronary artery bypass grafting, it's increased. But in the plaque taken from those same patients, you'll notice that sphingomyelin is much increased. And what he was able to show is that sphingomyelin increases calcium accumulation into cells, particularly when oxidized cholesterol, when the cells are exposed to oxidized cholesterol. He then looked at the concentration of oxidized cholesterol or oxysterols in the plasma of coronary artery bypass patients compared to controls. And he found that there were certain oxysterols which were increased substantially in patients in blue versus controls. And I think that this slide is wrong, because what we should have, and I apologize for this, is that the patients are in red and the controls are in blue. And I didn't notice that beforehand. But anyway, that is the truth, that sphingomyelin is increased. Sorry, the oxysterols are increased in the plasma of coronary artery bypass patients. So the theory he came up with is that LDL becomes oxidized in the plasma for various reasons. That causes oxysterols, and the oxysterols then promote atherosclerosis by promoting sphingomyelin uptake of calcium, which promotes atherosclerosis, which then inhibits the blood flow. Living on a diet high in trans fats or polyunsaturated fats changes the cell composition, particularly with the incorporation of trans fats. The trans fat replace the essential fatty acids, and what that causes an inhibition of prostacyclin production by those cells, and prostacyclin is necessary to prevent blood clotting. That then leads to blood clotting and sudden death. Others have embraced his ideas, and here's Dr. Ramsden, who you'll recall was the person involved in the Sydney Diet Heart as well as the Minnesota Coronary Experimental Recovery Studies. And in this article, he did a meta-analysis which again convinced him that polyunsaturated fatty acids are causing problems. And he said that this is how they work, that in the diet, the linoleic acid, the polyunsaturated fatty acid, the omega-6 fatty acid, linoleic acid, causes oxidation to happen of the LDL cholesterol, and the oxidized LDL cholesterol then interacts with the LDL receptor of the vascular endothelial cells, with macrophages, and with vascular smooth muscle cells, that in combination they then cause or explain coronary atherosclerosis. So again, it seems that the evidence suggests that it's the oxidized cholesterol that is important, and this gives a mechanism for that. And it appears that polyunsaturated fatty acids are involved in the oxidation of the LDL cholesterol. So in his final article, one of his final articles, Camero wrote, 2 lipids present in the diet, oxysterols and trans fats, and not cholesterol in the plasma, are responsible for heart failure. The cellular events that occur during the progression of heart failure are as follows. Changes first occur at branching points. There's a significant increase of sphingomyelin at branching points of the arteries, and those with heart disease have an increase in sphingomyelin in these arterial walls. Oxysterols, that's the circulating oxidized cholesterol, increase sphingomyelin synthesis, which leads to calcium binding in the arterial wall. Eventually, this causes the blockage of blood flow in the coronary arteries. And his conclusion is the most effective way to prevent coronary heart failure is to eat moderate amounts of foods, and particularly to avoid commercially fried foods and too many polyunsaturated fats. The banning of partially hydrogenated fats would eliminate trans fatty acids from human consumption. So I include this point to focus on the role of polyunsaturated fats, because I know as we talk about a low-carb diet, and I've been promoting a low-carb diet as well, but probably we've underestimated the toxic effects of polyunsaturated fats, and that's obvious because we kind of just assumed that they would be fine, they couldn't be harmful. Well, I think the evidence is growing that they are potentially harmful. So we come to the final slide, the summary and conclusions of all these 10 points. And these are the points which I've learned from this set of slides. There are more, but I hope I've made the point and that you will appreciate and agree with these conclusions, because I think they're terribly important as we advance our argument for the benefits of a low-carbohydrate diet. Firstly, it's important to distinguish true cause from reasons for a condition. And we've got blindsided by epidemiology, which offers all these reasons for a disease but can't tell us what the true cause is. I would say that the failure of cholesterol-lowering drugs to abolish all manifestations of coronary heart disease indicates that cholesterol is not the causa vera, the true cause of coronary heart disease. And what the cholesterol-lowering studies show is that the lipid hypothesis is false. But you see, they pad it up to say, well, you see that the statins do prevent a few heart attacks, although they don't affect mortality, so therefore the theory is still true that the lipid hypothesis is correct, that blood cholesterol concentrations cause heart disease. That's not true. The fact is the statins are meant to remove all evidence of coronary heart disease. And in fact, if you look at the statements of some of the people who promoted these drugs early in the 1990s, they said, well, heart disease will disappear in the early 20th century. And it hasn't. It's got worse, if anything. So that's my interpretation. We've been fooled by our epidemiology friends telling us that these are the reasons. We've got to focus on cause. And if you can't reverse a disease, you don't know what the cause is. And we do not know what the cause of coronary atherosclerosis. All we know is that the lipid hypothesis is false. In population studies, diet is a minor determinant of the blood cholesterol concentration, and I gave you that evidence in the 7-country study and the Framingham Heart study, and there are others as well. So if that is true, even if the lipid hypothesis is true, which is not C2 above, differences in heart disease rates between different populations cannot be due to differences in diet, because the cholesterol values are not determined by the diet. So the diet heart hypothesis is false. And that point is not made enough. So by finding that diet does not determine blood cholesterol concentrations in populations, and populations which may differ in the rates of heart disease, for example, the Japanese versus the Americans, then the diet can't be the factor that explains that phenomenon. And I gave you the Nai-Hon-San data showing that Japanese living in different countries have the same mortality despite differences in risk factors. So it's the fact of living in a different country that's the problem rather than the risk factors. Dramatic reversal of supposed major coronary risk factors failed to reverse CHD, all-cause mortality, in the Mr. Fit trial. And that is the most comprehensive trial ever undertaken. It will never be repeated. And so we have to accept the data and ask the question, are risk factors really the cause of disease? The most important dietary change in the US and elsewhere over the past 100 years has been the increased consumption of omega-6 polyunsaturated fatty acids, PUFAs, and not an increased animal fat consumption. And the point of this slide is that the whole basis for the Keyes hypothesis, as promoted by Senator McGovern's Senate committee, was that it had been an increased animal fat consumption that had caused the rates of heart disease to suddenly rise in the United States after the 1920s. And we have evidence that that's absolutely wrong. So the next point is that replacing dietary saturated fats with PUFA is known to cause harm. And that's from the Recover Minnesota Coronary Experiment, from the Recovered Sydney Diet Hard Study, and from the Women's Health Initiative. And my argument is that it's unethical for any medical practitioner to prescribe a diet that is known to cause harm. Anything that is known to cause harm is unethical. And I think that's a point we need to keep stressing. And then finally, the popular explanation of how coronary atherosclerosis develops requires that the coronary arteries have an histological design that they do not have. And that's quite telling that that point has never been made. So thank you very much for your attention over these lectures. I apologize that they went over a bit, but I think that the information I've tried to provide does indicate to you that the idea that fats in the diet cause coronary heart disease is completely fallacious, and there's never been any evidence for that. So we need to look to other explanations, and some of those explanations I've been also covered in these talks. So thanks very much, and best wishes to you all. Bye for now.
Well, this is an absolute pleasure. I'm here with Professor Timothy Noakes and Professor Peter Brukner, both professors of sports medicine, and dare I say, two people whom I look up to immensely. Great to have you guys on.
Thanks, Paul. Lovely to be with you and Peter again after a break of some years.
Great.
So good to be in touch again.
Yeah,
Well,
Tim and I go back a long way.
30 or 40 years, I'd guess, Peter.
Yeah, we clearly met when we were young children. Yeah, and I have to credit Tim actually for first really opening my eyes to the whole low carb world. So I'm not sure my family would thank you, Tim, but I certainly do for my latest obsession, as the family would have it. And it was really Tim's experience that prompted me to start making some inquiries and doing some research. And so I'll be forever grateful to him for that. But so Tim, I mean, we've obviously come a long way with long way with low carb over the last few years. But it's fair to say that the world hasn't totally embraced it as yet. I mean, what do you think are the sort of the major barriers that we still have before we can get our message out there and convince people that that they've got to reduce their carbohydrate intake?
Yeah, I think the problem is at the medical schools we still teach the wrong stuff, and that's so ingrained and it's controlled by industry. And I don't want to start the conspiracy theory right off the bat, but the reality is that that the medical schools are teaching what they're told to teach students, and because the control is so powerful. Unless we change the teaching at the medical schools, we really won't make a difference. I think every doctor who turns to low carbs changes a lot of people's lives. And so doctors are critical that we should change their thinking, because it becomes like a virus if they spread it. But it's very difficult to get to the doctors. I'm fortunate I'm now actually able to teach some of the medical students at our university, and it's remarkable how open they are. But I worry, because I tell them all this stuff, and if they repeat it, I don't know what's going to happen to them. They'll probably fail the exams. So I mean, that's the reality. The resistance is so strong.
Well,
Yeah.
we're actually, within our college, Peter, the Australian College of Sports and Exercise Medicine Physicians, it looks like there's now some movement to actually be incorporating an element of low-carb nutrition within the official curriculum, and that's something that you and I are both involved in on the periphery there.
Yeah, that's exciting, and hopefully we'll continue to make progress in those areas. But the rest of the medical profession, I think, I heard you say once, Tim, that half of everything we learn in medical school turns out to be wrong. We just have to work out which half. And I think we haven't quite, the majority of the profession hasn't quite worked that out yet.
Well, I mean, it's absolutely amazing how much resistance to new ideas in the face of overwhelming evidence doctors can have. I mean, every so often I post on Twitter or something about experiences I have with other doctors, and I had a patient recently who had basically, reversed, type 2 diabetes, had inflammatory bowel disease, in remission, got off all medication, so on and so forth. And the endocrinologist was absolutely ecstatic and said, okay, yes, this is a very good reversal of blood sugars, so on and so forth. And in the recommendations, essentially recommended this patient go back onto their previous diet to lower their LDL cholesterol, ignoring the massive improvements and the multiple medications the patients had seen. How do we get past this fact that doctors are just wearing blinkers?
Yeah, I think it's also all about personal experience. So we've all had the same personal experience, and that's why we committed, because we saw it made such difference to our lives. But until people do that, it's very, very difficult. I just know the resistance is so extreme, and you can tell by the people. They're slightly overweight, they're a bit insulin resistant, and you know that they would benefit, but there's the cohesion of the profession is just so remarkable. I mean, you all know about my problems, but I've tried to get the university to apologize for what they did. It's like, no, we didn't do anything wrong. You were wrong. And see, even though I went through this trial, they still claim that that what I was saying is wrong, and they won't change the curriculum despite all the evidence. The resistance is unbelievable. So it goes right to the top, and I honestly think it's because they're looking over their shoulders and someone's looking at them, and I think it's usually industry, and they know that if they were to make wholesale changes, there would be major problems. And I honestly believe that if you are a medical educator, you have two choices. You either destroy the health of your nation by following the way things are, or you destroy your university by stopping getting funding from industry and teaching the truth. And so most people, they can't make that. Obviously, they can't make that choice. They said, let's keep the universities going, and rather than destroy them. Because I know if our medical school were to lose its funding from industry, it would collapse. And I guess that's typical for most universities around the world.
Well, then, given that we've got an absolute abundance of evidence, level 1 evidence, we've got randomized control trials then turning into meta-analysis and systematic reviews that low carbohydrate lifestyles are beneficial in so many aspects. Where do I, as a practitioner, sit with regards to my legal obligation? At the moment, I practice low carbohydrate medicine unashamedly. But am I putting myself at risk because I'm going against the norms of the profession?
I'll
let Peter answer that one.
Well, maybe we should ask Gary Fedke about that one. And I think now, I think that may have been the case a couple of years ago when Gary went through his issues and Tim went through his issues. I think now that there is starting to be acceptance, and you see now little sort of chinks in the armour, that the American Diabetes Association and the Australian Diabetes Australia are now at least sort of being dragged kicking and screaming, if you like, to acknowledge that low carb diets are a potential or a possible, effective diet. So things are slowly changing, but it's it's a very slow process.
Yeah, I tend to agree.
Tim,
I don't think you'd be at risk anymore. Certainly in South Africa you wouldn't because of my case. But it's still a long way from acceptance.
Now, Tim, I'm curious because you've obviously immersed yourself in this data for longer and deeper than most anybody else. I'm just curious about where you think the next scientific advances are, or where our knowledge is progressing. We accept the baseline premise that carbohydrates, insulin hypothesis, and oxidative stress from vegetable oils, but where's the science taking us now? What's exciting you at the moment in the literature?
Well, I think that as I talk about in my lecture, I think that polyunsaturated fats are the next area. And it's what I've learned in the last year or two, when I've gone into the more detail of the whole history of how we got to where we are, and that's what I try to present in my lecture. I've begun to realize that we accept information that is so flawed, and it just became part of it. We just accepted it. And the first point I made in the lecture was the fact that we don't understand cause, and unless you find the cause of a disease, you can't reverse the disease. And so we've been taken in by the epidemiologists saying us there are reasons for diseases, and we've called them causes, and they aren't. And if you can't find the cause, you'll never reverse the disease. So the first point I make in my lecture is that we do not know the cause of coronary atherosclerosis. So don't come and tell me I must change my cholesterol or something, because we actually don't have a clue what's causing the disease. So that's not going to help. And I think that's my first point, is that we've been confused. And so we accept that. And then we accepted that it was Keys told us that it's a change in diet and that we started eating meat and that caused us to get sick. And that's not true. We started eating polyunsaturated fats and less carbohydrates than I thought. So that linking carbohydrates specifically to chronic disease is I know it works through the insulin resistance pathways and so on, but there's a component that we have to be missing because we've excluded the polyunsaturated fats, and we've excluded it because we all thought it was healthy. I make another point in the lecture, and this comes back to ethics, that there are now 3 clinical randomized controlled trials: the recovered Minnesota coronary experiment, the recovered Sydney diet hard study right from Sydney, and then the Women's Health Initiative, all showing that if you replace saturated fat with polyunsaturated fats, you do worse. So it's unethical. It's actually unethical to prescribe polyunsaturated fats. And we don't make that argument, and I think that's where we have to go. But now you asked this real question, and I think it relates to that case you had recently that you reported in Twitter, and which I found very interesting. But it's a reversal of autoimmune disease. I think that's the next area, and the role of the gut and leaky gut syndrome in autoimmune disease. That's an area I think that could hold lots of benefit.
Look, as you know, that's an area that I've lectured on before, and I've got a particular interest in that. But if I could tell you a little bit of information you may not know about the Sydney Diet Heart Study. That was funded
yes,
by
please.
the margarine industry.
Yeah.
Funded by the margarine industry. So I had a phone call a couple of months ago from somebody who said, actually, do you know who was behind this? And I actually just had a call from a journalist, actually just 2 days ago, again, discussing the particular company, and they've actually been approached by this journalist, and they've claimed that they ran out of money. So they managed to collect all the data, but then they run out of money to actually process the data, which I think we can probably take with a handful of salt. And that's the reason that the data wasn't originally published. And if it wasn't for Chris Ramsden, the guy who basically went into a basement and discovered these 9-track magnetic tapes, then this important information, from memory, I think the group that had the polyunsaturated fat, they had an increase in mortality of something in the order of 62%. As
that's
you
right.
say,
That was, yeah. And that data were available on the first analysis. If you go and read the original paper, it shows that the mortality was increased in the group getting the polyunsaturated fats, but that they kind of hid it and reported it, and then they hid it in another journal. It was not an easy journal to get hold of. So that's the typical way. And in my lecture, I describe all the types that's happened. It's happened so often. It's not by chance that it happens.
Well, I'm really impressed with your analysis you did of the Women's Health Initiative. I think you published it in the South African Medical Journal several years ago now, where you actually managed to go through the data and you found the only statistically significant finding for the entire $700 million study was buried on page 661 of the journal in an incredibly obscure sentence. I literally have shown this sentence to doctors, and they've looked at me with a blank look on their face and they said, well, what does that mean? Because it's something along the lines of the HCAR, was 1.26, and it doesn't really bear any elaboration, and it's really out of context. I mean, this is academic fraud, if I'm not being too strong.
Well, one of the senior authors was a man who I've had a lot of fights with over the years. And what's really funny is that his son works at the University of Cape Town and wrote 35 blogs saying what a bad scientist I am. I mean, this is the social media attacks on me were, apart from everything else that happened, I had the social media attacks. And he was one of the drivers. So it was the son of the guy who died exposed. And what was interesting was the son never went and told his father that he was a useless scientist and was perhaps practicing fraud. But I also in the lecture, I also show how they modified one table and how they subtly, so you couldn't see what the truth was. So if you didn't read the paper closely and you just looked at the table, you'd completely miss the only significant finding on that table, that hidden. So when we pointed it out to Professor Rousseau, he said, "Oh, it must have been a printer's error." So I said, "Fine, we'll correct it." Well, they still haven't corrected it.
I mean, well, it's an absolute joke, but it actually got worse than that, because there's one thing to sort of not disclose data, but then it's another to deliberately misrepresent it. And I went back and I was looking at some of their old press conferences, and their conclusions that they were stating in the press conferences, they totally ignored the fact that if you had the females with history of heart disease who went low fat actually had that 26% increase in risk. And they said, well, this just goes to show that a reduction of dietary saturated fat of 8 to 10% is not enough. This study is evidence that we have to have stricter reductions in saturated fat. Totally contrary to any evidence.
Yeah. No, well, Professor Rousseau was involved in my case. So he was about to give evidence. And unfortunately, my legal team had destroyed all the other expert witnesses. And he suddenly realized that if he was to go onto the witness stand under oath, we would have exposed all of this. And he would have been severely embarrassed. And at the last minute, literally at the last minute, he pulled out as an expert witness, because he knew Dr. Rocky Ramdas, who was my chief support lawyer, would have destroyed him, and all of this would have come, and we would have had him on the stand for 2 days, and we would have loved it. But he was clever enough to make sure. But the point is, at the very time that the South African organization that charged me, the Health Professions Council of South Africa, at the very moment that they were deciding whether to charge me, he suddenly arrives in South Africa and gives lectures on the value of the low-fat diet and the Women's Health Initiative. At the very moment, funded by Unilever. Just make that little point. He arrives in South Africa and starts talking to the dietitians about the Women's Health Initiative study. So this is 2014. This is 2005. It's how many years? 9 years after he'd published this potentially fraudulent data. He's still saying the same thing in South Africa. Yeah.
There's a bit of a whiff around that.
Yeah. Well, the whole, let's not go into the trial, but it was all made up. So he was just part of that.
Tim, we're running out of time, so we better finish it up there. But thank you very much for your contribution to this this conference. It's been immense. You've been an inspiration to many of us for a long time, and I'm sure you will continue to be. And we really appreciate your time today.
Thanks, Peter, and same to you. You know, you've inspired me. Your book on sports medicine is the Bible. It's an astonishing achievement, and I've said that so frequently that one of the greatest contributions to sports medicine is your and Karim's book globally. It's unmatched in anything I've recognized. It's an astonishing piece of work. So I'm glad I could inspire you, but you've done an incredible amount, and you need to be thanked for that as well.
Wow. I think we better finish this Mutual Admiration Society, Paul, and put it back to you.
I was just thinking, I was glad to be witness to that. Look, I have to say, look, and I haven't mentioned this earlier, very early in my low-carb journey, it was actually an editorial by both of you gentlemen that you co-authored in the British Journal of Sports Medicine that really struck home and resonated with me. So I owe an enormous debt of gratitude to you both. And certainly my health is much better now than indeed it was when I was in my 20s. So it's I thank you both sincerely.
Well, thank you, Paul, for all the work you're doing, and you're applying very rigorous academics to your work, and I appreciate that very much.
Thank you.
Thank you both.
Thanks, guys.